Then our next presenter is Cecilia. We'll just wait for her to load her presentation. There we go. And we will continue. I just want to remind folks, obviously no lunch hour, so just go ahead and have lunch on your own. All right. Our next presenter is a member of UM-NSU CARD. She also works at the ASAC clinic. She's a BCBA, does a lot of great work for the University of Miami. Cecilia Alvarez-Tabio, and her presentation is on evidence-based practices in coaching parents and teachers. Cecilia.
Hi, can everybody hear me?
Yes.
Okay, perfect. Obviously I'm sharing my screen. So hello, everyone. Thank you for listening to this great conference. My name is Cecilia, of course, as Louis introduced me. And what I want to do today is talk about evidence-based coaching practices for early autism intervention. My goal is really to highlight the importance of providing evidence-based training to parents and early childhood educators of autism. What I'm going to do is review a few coaching models that I've used for the past 10 years in coaching parents and teachers. So as Louis mentioned, I do work with CARD as a clinician. I also do clinical work at ASAC, and I'll talk a little bit about that later. But as a clinician with CARD and in my career as a BCBA with background in coaching and training, I interact with many families and teachers who really complain a lot about their limited ability to interact or teach their child with autism. They neither have the tools nor the training to effectively do so. So, for example, they see or hear how the child interacts in a structured therapy clinic with trained clinicians, but they cannot replicate that at home or in the classroom. So much of my efforts these days is focused on coaching, especially parents and caregivers and teachers in preschool classroom, because I want to take advantage of early intervention. Let's see if my cursor works. So like Dr. Alessandri mentioned, we're diagnosing autism earlier, and the hopes is that we are able to do it even at an earlier stage. But this early diagnosis have brought about the emergence of early intervention and the development of specific interventions for young children that are similar, empirically supported, and they represent the merging of applied behavioral and developmental sciences. So what I'm going to talk about today, and the focus of my talk is talking about NDBIs, which Dr. Alessandri also mentioned, and that stands for Naturalistic Developmental Behavioral Interventions. And this is a term that has been recently created to unify the field around interventions that have a shared set of characteristics, behavioral and developmental, and how we can incorporate this approach to help parents and teachers to also become early interventionists. Before I begin talking about models that incorporate the NDBI approach, I want to quickly review the trajectory that many years of research has shown us about teaching individuals with autism. To begin with, like Dr. Alessandri mentioned, the research has demonstrated that interventions based on ABA are effective in teaching skills to individuals with autism and reducing challenging behaviors. If we start looking at early work and operant learning as an approach to teach individuals with autism a variety of skills like language, social, play, self-help, and academic skills, as well as the reduction of challenging behaviors that interfere with that learning. To research that was conducted on infant and child development that provided different models of early developmental processes that are involved in communication, language, and social learning. Other treatment strategies and models were targeting skills that were precursors of language development, like joint attention, and pivotal skills that provided foundations of learning other skills like imitation and social engagement. And other studies looked at the role of social relations as essential for the development of imitation and foundations of communication, because they started realizing that children with autism had deficits in effective sharing and social motivation. So interventions began incorporating strategies to promote effective engagement. So many researchers and clinicians have moved toward developmentally focused models where ABA interventions are delivered within a naturalistic or naturalistic activities and routines. As these interventions have evolved, they have increasingly begun to blend developmental theories and interventions with ABA. And that's how they came up with the name NDBIs, or Naturalistic Developmental Behavioral Interventions. So in a nutshell, NDBIs combine effective teaching methods based on the science of ABA with developmental methods known to enhance motivation, engagement, and learning. And so this blend is then used to embed the learning into activities that are appropriate and fun for individuals and families, regardless of their age and developmental level. So with the understanding that autism is a developmental disorder that affects every area of a child's development, these interventions started to target all areas of development. So they would write objectives following the developmental sequence of typically developing peers in each domain of early childhood development with the goal of really minimizing delays associated with autism. We know that children with autism, or the children who develop autism, experience social interaction, but they may not find it as rewarding. Therefore, they miss out on lots of learning opportunities. So they're not watching what the social life of the family or classroom. They're in the periphery of the room, interested in other things, but the social interaction of the family or their peers. So these interventions that I'm going to talk about today make it a point to create opportunities where they learn on imitation of what people do with objects, with their faces and their bodies, voices and sounds, and use those to learn how to handle tools, how to take care of themselves, how to play with other children, how to speak, carry out tasks during the day, how to use gestures. So the learning occurs from activities through all senses. So we capitalize on what we call multimodal learning through routines. And because we sometimes have difficulty with generalization, we like to involve caregivers and other adults who spend time with our children in different settings. Some of the common features that are behavioral strategies to teach these developmental skills are arranging the environment so that teaching occurs in a more naturalistic and interactive social context, like during play or during daily routines. And they involve mostly child-directed teaching strategies. So they really use child prefer materials, so work on that child motivation and taking advantage of that in a particular activity. The use of ABA principles like antecedent behavior and consequences to help the child understand when to respond and to provide feedback to the child. Taking advantage of natural reinforcement. So allowing access to a toy after the child has imitated its use in maybe a symbolic play act. Using prompting techniques, so providing the cue after the discriminative stimulus is given and the target behavior is actually done to elicit desired response and delivering a reinforcement. Focusing on reciprocal interactions, so really looking into or working to develop that turn taking to increase that social reciprocity and maintain that turn taking with materials. Using modeling as a form of prompt to teach a target skill, and also imitation. So the adult imitates what the child is doing to increase attentiveness to the adult, and in turn, the adult would imitate the child will imitate the adult and continue the interaction. writing individualized objectives, using manualized protocols, and implementing to fidelity. So moving on to evidence-based models that coach parents on these skills. So the main goal in these models is to bring toddlers with autism back inside the social circle of the family life and increase their interest in those social interactions. So we want to teach them the main skills in social learning, like imitation, so they can learn by observation, joint attention, which Dr. Alessandri mentioned at the beginning of the talk, which is a skill that allows them to coordinate their back and forth communication with a person, along with the object that they and the other person are sharing. So this is a skill that is a very fast way to pick up on language and concepts about the object, and we want to really target these skill early on. Verbal and nonverbal communication. We also want to make sure that we have worked on both kinds of communication as far as long as possible within the first 5 years of life, because we want to fill in those gaps before they get bigger. And we want to give young children with autism a solid base for moving into school learning. And last, play skills. These skills are learned from other people, and it is very effective in autism. So play skills are critical in learning, peer interactions and peer relations. So we need to work with young kids with autism on how to play appropriately with toys and how to carry out symbolic play. So these excellent NDBIs are used and taught at the clinic by trained therapists, but they are limited to a set of number of hours each week. So they don't work with a child in everyday situations. In other words, they don't always generalize. So we want to focus on coaching parents. We coach them to use language-supported activities in naturalistic settings to fill in the gaps. So the parents learn to take advantage of these learning opportunities through daily routines. Across environments and over time. So they learn these skills so they can use them while they're doing groceries or during bath time or when they go to the park or when they're getting dressed. Let me make sure things are okay. Okay. Sorry, I'm looking at my chat. All right, so moving on. So one of the NDBIs that has received significant research results in the past year is Project Impact. And we have been offering this virtually through the ASAC clinic, which is housed in the Department of Psychology, for those of you who don't know. It incorporates these naturalistic behavioral and developmental teaching strategies to really facilitate that communication between the child and the caretaker. And this is really targeted for children between the ages of 18 months to 8 years. So it really is meant to foster the child's relationship with the adult, and focusing on developing reciprocity, social engagement, and share affect during those interactions, while also integrating behavioral strategies like direct prompting, contingency reinforcement in the context of that interaction. So they really focus on 4 core social communication skills, and they are social engagement, language, imitation skills, and play. So research indicates that parents can learn developmental and behavioral strategies with a high degree of fidelity, and that the use of these strategies also result in increased language development and social engagement in the child. Research has also indicated that parent training is time and cost effective, and leads to increased generalization and maintenance than just therapist implemented intervention models alone. In my opinion, the combination of both is the ideal situation. So just a quick note, the authors for Project Impact, Ingersoll and Borsak, decided to test the same training curriculum used with parents at the clinic, in the clinic setting. They decided to implement it in a classroom-based intervention model with teachers that included teachers working with parents. Given that the majority of young children with autism receive intervention services through the public schools, they decided to focus on the early intervention classrooms, ESC classrooms. And the teachers that participated found that the program to be appropriate for use in their ESC settings and very user-friendly. And the parents and teachers both reported significant gains in the child mastery of social communication skills. So in talking a little bit about the model, the impact model, the strategies allow parents to meet their child's individual goals, because goals are written at the beginning of the intervention, by using them within their daily routines and interactions, like play interactions. They have 5 sets of intervention strategies that really build on each other, and they're focus on your child, adjust your communication, create opportunities, and teach new skills. Well, and shape the interaction. So what we do is we, each week or each lesson introduces a new strategy set. And the idea is that by the end of the program, the parents can use all of them together to help their child reach the goals they have set for him or her. So just to quickly go over the rationale behind each strategy, first, they use this pyramid to kind of explain it better. So we start with the strategies at the base of the pyramid, which are focus on your child and adjust your communication. And we start with these strategies to help the child engage with the parent and the activity. And together they are the starting point. So the majority of the time, parents are going to use the strategies, these 2 strategies the most, and they're always going to go back to that. Next, the parents learn the strategy set in the middle of the pyramid, which is creating opportunities. And so what this does is it helps a child initiate or start the interaction with the parent. And if the child doesn't initiate, then the parent will use the strategies to help the child initiate and to gain his or her attention before they go on and teach new skills. Then the parent learns the strategy set at the top of the pyramid, so which is teaching new skills. And so this strategy set involves using prompts and rewards or reinforcement to help the child communicate or play in a new and more complex way. So one session is spent on teaching parents how to teach new communication skills to their child. And another session is spent on teaching the parents how to teach new imitation and play skills. So by the end of the program, the parent learns how to shape the interaction by really moving up and down the pyramid based on how the child is responding. So the parent will shift between strategies that are more playful and keep the child engaged and having fun, and strategies that are more supportive and teach a child new skills. Another coaching model that I developed at CARD, doing a lot of literature review and looking at research that's been done in the past, and also working in conjunction with my colleague Lori Weiss, I developed Project GRASP. And Project GRASP is I created this manual for clinicians who want to implement this coaching model with parents at the clinic. So the focus is joint attention, communication, and play skills. As the acronym describes, giving, reaching, attending, showing, and pointing are all behaviors used in joint attention. And so what the therapist uses behavioral skills training to coach the parents. So the therapist provides that didactic instruction to the parents, then models the strategies for the parent, then the parent, while the parent watches, and then the parent practices the skill, and finally the coach provides the feedback. And so all these GRASP skills are embedded in the lesson plans. So the lesson plans, mostly I was focused on play skills, on simple plays that parents would do with their child. So within the same activity, the coach would work on the GRASP behaviors, because the idea was to get them started with these prep skills as stepping stones to developing and generalizing joint attention. So moving on to models that teach similar skills in the classroom setting, I want to talk about a research study that I was involved a few years ago called ASAP. So the purpose of ASAP was to help teachers, therapists, and others who work with the children in the classroom foster the development of important communication and play skills in young children with autism within the classroom, the school day. The goal was to provide materials and strategies that could be blended in successfully with the variety of different curricula used in the public school preschool programs that serve kids with autism. And the goal of the coach was to teach the team, which was composed of the teacher, teacher assistant, and a therapist, behavioral strategies to teach the skills to the children. What you're going to see in a few slides is that the teaching materials were presented in a structured way to help teachers understand the child's individual developmental needs and help them set goals for the school year and in their IEPs. And we all know how the IEPs look like and how vague these goals could be. So the materials used in the intervention provide a clear understanding of developmentally appropriate categories and how children should progress. So just to talk a little bit more about the ASAP model, basically the ASAP model had a developmental progression of skills between the two content areas, social communication and play. So the intervention team, along with the coach's help, worked together to develop these skills in two contexts. The one-on-one interaction with an adult in a group setting that involved peers. So the one-on-one basically allowed the team to maximize the learning opportunities using behavioral strategies to teach the skills. And the group setting provided an opportunity for generalization to occur. So they would practice skills with different people and across different activities throughout the school day, facilitated by any of the team members, while also obviously using the behavioral strategies. So the combination of both would promote the development of these social communication and play skills and enhance engagement with the adults, peers, and objects in the environment. And what they refer to by engagement is to the time spent in meaningful and developmentally appropriate activities. This enhanced engagement would increase more learning opportunities that could in turn increase learning in other developmental areas like socialization, language, and adaptive skills. So the idea was that the improvement in social communication and play skills was meant to have ripple effects and improve other important skills for the child. The play objectives on the ASAP intervention were divided into developmentally ordered categories, starting with exploratory play all the way to functional and symbolic. And these skills tend to develop in sequence, but there could be overlap. For example, I would tell teachers, children who engage in functional or symbolic play could still engage in lower levels of play like exploratory or relational. So I would tell them, make sure that you observe the children in multiple situations or tasks to determine their skills correctly and write realistic goals. The social communication objectives addressed in ASAP were divided into 3 categories based on the way that these skills develop in children. So they came up with this pyramid to illustrate how the skills fit together. The ultimate goal for the social communication development was for the child to initiate and respond to joint attention. So the way that it was presented to the team, I explained that communicating for joint attention involved being motivated to share interest on an object or an event in the environment with another person, as well as coordinating attention between that event or object and that person. So the idea was to develop skills for social interaction and requests as important stepping stones to develop joint attention. So here's an example of the play skills. As you can see, the different categories of play were presented in a step-by-step manner and provided a structured way to teach the skills and to set goals. Here's an example of the social communication categories and the developmental sequences in a step-by-step format as well. It really made it easier for the team members to set up goals and understand how it should look developmentally. So overall, the results demonstrated changes in the environment. Overall, it demonstrated changes in the engagement of the child, which translated into meaningful interaction with objects, peers, and adults. So the teacher and the service providers demonstrated high fidelity of implementation of the intervention, and they also reported how user-friendly or easy it was to use and implement. So my goal in this presentation was to highlight the importance of providing evidence-based training to parents and early childhood education in autism. So with early diagnosis increasing and helping with early interventions, we've seen amazing improvements in young children with work done by trained therapists. So these early interventionists have increased their use of NDBIs. So they're teaching developmental skills in a more naturalistic setting to promote the generalization while using behavioral strategies to understand the effects of antecedents, behavior and consequences, and building and shaping the child's behavior. So why not capitalize on family and the family circle, like the parents and the child's educators, the teachers, who are really true experts on the children. Last but not least, if you're not connected with CARD or ASAC at the University of Miami, I invite you to reach out to any of us. CARD is a great resource for families and early childhood educators. And ASAC, it is a private specialty clinic that provides some of these services at a cost. But because we're providing these services virtually, we can serve families in Miami-Dade or Broward. So feel free to reach out to any of us if you're interested. I just wanted to show this last slide with some of the models that are that incorporate this NDBI approach. And they're primarily available in university-based research settings, but others are more readily available in the community. They each have their own specific feature, and there are differences among them, but they all target the same skills they want to develop these deficits that young children with autism present. And with that, I thank you for giving me the opportunity to talk to you about something that I'm very passionate about, and feel free to ask questions in the Q&A later on. Thank you.
Thank you, Cecilia. That was great. Thank you for everything you do for CARD and for the different aspects of your role with the University of Miami. You have your hands in many different things, so we all appreciate it. So thank you. Thanks.
You're welcome.
Before we get to our next presenter, which will be Dr. Parlade, she's loading up her presentation. I just want to make a couple of comments. Obviously, for those families that are on the chat today and are not registered with CARD, please do so. You can on our website now. We have a simpler process, a one-step process to to register with the center. It's an online form that you fill out on our website, and then you have the option of being contacted by a CARD caseworker after that as part of the form. But now you can register online with us. And then for those folks out there that are not receiving our email blast, you can receive our email blast twice a week. We have information from community providers on one blast, and then the other email newsletter you'll receive is CARD information, workshops, trainings, groups, those things that we're offering as well. If you're not a member of the email blast, you can also sign up for that on our homepage on our website at umcard.org. That's umcard.org. Okay, moving on. Our next presenter is Dr. Megan Parlade. Amongst many of the different things she does at the University of Miami, she's a licensed psychologist. She's a co-director of the ASAC clinic, and she's also a professor with the university. And she does a lot of work for CARD as well. So she's going to speak to us today about parent-child interaction therapy for children with autism spectrum disorder. Dr. Parlade.
Yes, thank you. I'm hoping you can see and hear me all right, and the slides as well.
Yes, you're good.
Excellent. All right, so as Lewis mentioned, I am a clinical psychologist at the University of Miami's ASAC clinic. I oversee the Pcit services there in the clinic, which is actually a satellite location for the larger Pcit program out of the Mailman Center for Child Development. So today I'm going to be talking to you about Pcit, and I am thrilled. Pcit is one evidence-based treatment option for children with autism who are exhibiting disruptive behaviors. Been doing Pcit for about 10 years now, and it's hands down one of my favorite interventions. The amount of change that we see in such a short period of time is remarkable, and I just love that it really engages the whole family in the treatment process. So going back to what Dr. Alessandri talked about at the very beginning of the talk today, it really highlights the parents as the agent of change in their child's treatment. So here are the objectives for today's talk. I don't have any conflicts of interest, but I do want to mention that Pcit, the program at is supported by funding by the Children's Trust of Miami-Dade County, which allows us to provide Pcit services for free to families in Miami-Dade who qualify. And our program is really a collaboration between the Children's Trust, UHealth, the Mailman Center for Child Development, CARD, ASAC, and of course the Pcit team. Okay, so you can see here a list of terms on the left: tantrums, noncompliance, irritability, defiance, aggression. How many of you have observed these types of behaviors in your clients, or had parents come to you asking for help with these types of behaviors? Or if you're parents yourselves, how many of you struggled in managing these behaviors in your own children? These behaviors are actually very common among children with autism. As many as 50% of children with ASD exhibit these types of behavioral challenges. And in fact, disruptive behaviors are the most common presenting problem for children with ASD seeking community mental health services. Around 25% of these children also meet criteria for oppositional defiant disorder or conduct disorder in addition to ASD. And around 68% display aggression towards a caregiver. Now, these behaviors are extremely noteworthy because they have the potential to interfere with performance of daily living skills, limit the child's ability to benefit from educational and therapeutic services, and may increase social isolation. And uncertainty on how to manage these behavioral problems may also amplify caregiver stress and increase teacher burnout. So behavioral parent training is an empirically supported intervention for children with disruptive behavior uncomplicated by ASD. So it's commonly used to treat children with ADHD, oppositional defiant disorder, and other disruptive behavior disorders. Parent training provides parents with specific techniques to manage problem behaviors in their children. Parent training for families of children with ASD, I think, warrants interest as a potential intervention model for several reasons. So parent training is considered an efficacious treatment for neurotypical children with disruptive behavior. It's traditionally short-term, delivered during brief 45 to 60-minute weekly sessions. And as I mentioned, it emphasizes the role of parents as the agent of change, which promotes generalization to the home and other settings. Now, 4 different behavioral parent training programs have been evaluated among children with ASD, and these include the Ruby program, the Incredible Years, Triple P, and Parent-Child Interaction Therapy. So let's talk specifically about Pcit. So Pcit is one of the strongest evidence-based treatment models for young children ages 2 to 7 years with social, emotional, and behavioral challenges. It was developed 50 years ago, originally as a way to treat young neurotypical children with disruptive or externalizing behavior problems, including conduct and oppositional defiant disorder. The Pcit is a little different than what we've been hearing about so far in that it didn't start out as an autism intervention, but it does share many similarities to the NDBIs that we just heard about, in that it blends developmental principles and behavioral science. Pcit places an emphasis on improving the quality of the parent-child relationship and changing negative or ineffective parent-child interaction patterns. But unlike many of the other behavioral parent training programs that I just mentioned, children and their caregivers are seen together in Pcit, and it involves live coaching of parents' use of their skills while they interact with their child during play. And results of decades of research have shown reduction in child disruptive behavior, increase in child prosocial behaviors, reduction of parent stress, and improvement in parent-child attachment. So after Pcit, children's disruptive behaviors are within the normal range, so not at clinical levels anymore. And research also has shown generalization of these gains to the school setting and to untreated siblings. And these positive outcomes have been shown to be maintained up to 6 years post-treatment. So this graphic here highlights a recent study that employed one of the largest community research samples conducted with Pcit, so around 2,700 children and their families across the state of Oregon. And this study showed that for families who graduated from Pcit, they demonstrate a very large effect size in problem behavior intensity improvements. But we also see here that families who terminated treatment early, but attended at least only four sessions, still showed significant improvements in behavior problems with a medium to large effect size. So large effect size is 0.80, and we're right close to that point. Now, these effect sizes surpassed those reported in studies of other treatment approaches for child behavior disorders, including stimulant medication, CBT, and some of the other behavioral parent training programs. Now, this study was not exclusive to children with ASD. It was a large community sample that did include some children who had ASD or other developmental delays, but it didn't focus on that population specifically. Now, as I said, Pcit has traditionally been or was developed to treat children, neurotypical children with disruptive behaviors, but it has, since its inception, been studied with a lot of different populations and shown to be effective across various populations and cultures. So that includes ethnic minority groups, children with chronic illness, children with at-risk or for maltreatment or abuse, children with anxiety disorders, children with hearing impairments, and children with intellectual or developmental disabilities, including ASD. And I'm going to talk about some of that research specifically a little bit later in the talk. Now, why do we think Pcit specifically would be beneficial for children with ASD? Well, one, we know it's effective for children without ASD. Overall, the goals and treatment outcomes of Pcit align very well with those who are relevant, those that are relevant for children with ASD. So Pcit strives to increase school readiness skills by increasing child compliance, improving language and social skills capabilities, increasing attention spans, expanding the play repertoire, increasing compliance rates, and decreasing oppositional aggressive behaviors. And similar, as I mentioned, to the NDBIs used to treat young children with ASD, Pcit integrates concepts from applied behavior analysis and developmental sciences. Pcit may also hold benefit for many children with ASD because it has a high level of structure built into the program. As I mentioned, it relies on behavioral principles. It uses repetition to teach, and it focuses on caregiver involvement and interaction, which is central to the intervention. Further, and I think this was also mentioned by Dr. Alessandri at the beginning, many families still don't have access to other evidence-based behavioral interventions for children with autism and disruptive behaviors, including ABA. Or if they do, their ABA program may not involve the parent in the treatment, or the parent training may be minimal, leaving parents unsure or ill-equipped to handle these behaviors on their own. So to highlight some of the key features of PCIT, what makes PCIT so different and unique from other behavioral parent training programs is the way the skills are taught. So both parents and children come to the treatment sessions together. And the skills are taught to the parents using a live coaching model. So the parents receive live and ongoing feedback from the therapist while they're engaged in play with their child. Sessions are 1 hour per week. And then parents are also assigned daily homework to complete where they're practicing these skills for just 5 minutes each day. And the therapist and the parents work together to talk about how they can use these skills outside of that concentrated practice and treatment sessions to help generalize the effects and generalize their skills throughout the day. Another important feature of PCIT is that the treatment is data-driven. And this is a very important component of any treatment for ASD, is that we use data to inform treatment. So targeted behaviors, parent skills, child behavior problems are identified at the beginning of treatment and are measured and graphed over time to highlight the process or the progress being made by both the caregiver and the children or the child. And families graduate from treatment when parents demonstrate specific skill criteria, and they also rate their children's behavior as being within normal limits. PCIT is also manualized. So the manualization helps with training and consistency of treatment implementation among intervention providers. There's also a pretty involved certification process to become a PCIT therapist. With consistent attendance and homework completion by the family, PCIT is typically provided in 12 to 20 sessions, with an average about 12 to 14 sessions, as I mentioned, each session lasting about an hour. There are some models that use a time-limited or session-limited approach, our program being one of them as well. And this approach shows comparable treatment outcomes to the criteria or mastery-based PCIT. So to unpack the live coaching piece a little bit, so you can see here at the top, this is what PCIT would look like in our clinic, actually, specifically. This is our clinic at ASAC. This is me holding the microphone. So the therapist would be able to communicate with the parent and the child on the other side of a one-way mirror. They're engaged in play and the parent is wearing an earpiece or an earbud, allowing them to hear the therapist, giving them feedback and suggestions and reinforcing the skills that they're using with the child in play. Because this is the traditional setup for the model, the therapist is spending very little time in the room with the family at all. It's really about the parent's interaction with the child. And the setup actually lends itself very well to telehealth, which has been unfortunately a necessity this past year. But we were using this model to deliver PCIT even before the pandemic. And down here, you can see a picture, a screenshot of what that might look like. So we're able to deliver PCIT in family's home. You can see here, and it's blacked out because we typically turn our video off when we're engaging in the coaching session so as not to distract the child, but the therapist is on the call and providing that same live feedback and coaching to the family while they're in their home. So PCIT, to get a little bit more into kind of what it looks like, it's developed or delivered in 2 different phases. So the first phase is called child-directed interaction or CDI. And this is what we also refer to as the relationship enhancement phase. So the focus is really on developing and establishing a nurturing and secure relationship with the parent and the child, while also increasing the child's pro-social behaviors and minimizing or decreasing those negative behaviors. So the goals are really to increase that positive parenting, their responsiveness and warmth towards the child, decrease negative attention-seeking behaviors in the child, and improve pro-social behaviors. The second phase, PDI, or parent-directed interaction, parents are learning to set consistent and clear limits and effective discipline. And so parents are taking more charge of the sessions in this phase, where they're leading more of the play and they're being taught, again, to be able to set these appropriate and consistent limits And we're able to address any remaining behavioral difficulties at this point, specifically decreasing defiance and aggression. And we also tend to see big improvements in children's self-regulation or emotion regulation during this phase, as children are also learning to kind of navigate the bounds of those limits and control their behavior to be able to stay within those limits set by their parents. Each session is structured in a very similar way. So first of all, each phase, the CDI phase and PDI phase, begins with what we call a teaching session, where we meet with the parents alone to go over all of the different skills and strategies that are going to be implemented and practiced in that phase of treatment. It's a lot of material to cover, so we do that in a very concentrated kind of didactic way, but we do use the therapist modeling of the skills, role playing with the parent to start to practice and get a feel for what those look like. And then after the teaching phase, and every other subsequent session until we get to the next phase is a coaching session. So the coaching sessions look the same each week. We start with a check-in, reviewing the homework, how things went that week for the family, any new stressors that we should be aware of that might be affecting the child's behavior or the parent's ability to practice. Then we code, we do behavioral coding with the parents where we're checking off how many times they're using each of the skills that we cover. And we use that information and that data to inform where we go in terms of our coaching, what we focus on, and how we support the parent in developing those skills. And then the rest of the session, or 30 minutes or so, are spent coaching the parent with the child. And if there are two parents in treatment, and we hope that there are both caregivers, then we'll split that coaching time between the two. At the end of the coaching, then we'll review our data with the caregivers, talk about the progression of treatment, talk about any changes we're seeing in child behavior, and assign goals to work on that week or our homework. So the skills that are taught in the CDI phase really are differential social attention. So we are teaching parents to provide warm, positive attention to behaviors that they like and they want to see more of and that we want to promote, and to remove attention or limit attention to behaviors that are not helpful or appropriate, or behaviors that we don't want to see more of. So we do this through the use of what we call the PRIDE skills, and it's an acronym here. So the PRIDE stands for praise, reflect, imitate, describe, and enjoy. So we teach parents to use specific labeled praises, so very specific praises, to reinforce behaviors that are meaningful for that child. And this may be different for every child. So for a child with ASD that maybe have difficulty even engaging in play skills or using functional play, then the parents would be focused on using these PRIDE skills and using that label praise to reinforce anytime the child is using functional play. For example, nice job stacking the blocks. Good job making the car roll around the track. And so, we can also use these to target social behaviors. Thank you for making eye contact. Thank you for looking me at the eye. Thank you for sharing with me. Great job calming down or staying calm when the tower fell down. So we can really use these praises to specifically target those behaviors that are most meaningful for that child. We also teach parents to reflect or repeat back what the child says, and that allows the child to feel like they're being heard. It helps the parent focus their attention on what the child's actually saying and doing. And reflection can also help increase vocabulary and language development in children. We also teach parents to imitate, which really means kind of engage in the play themselves. So instead of sitting back and watching, get in there, use the toys, play with the child, model, the appropriate or more developmentally advanced ways of using the toys, and really stay at that child's level. We also teach parents to describe or narrate what the child is doing. It's going to help focus their attention on the play, and also give more verbal input and improve or increase vocabulary. We also emphasize that this play should be fun. We want them to enjoy the play with their child, and can communicate that through shared smiles and physical touch, and to really kind of add that level of warmth. Oops. One more point here about the CDI skills. So we use the positive attention very strategically. So we use these pride skills when we see the child doing something that we really like and we want to improve. And we teach parents to selectively ignore or remove their attention to behaviors that we've identified as problematic or challenging. And this would be any kind of mildly disruptive behavior. So we can't ignore more severe levels of behavior like aggression or destruction of property. But for things that are more mildly difficult, whining, crying, we would teach parents to turn away and withhold their attention while remaining focused on the play and wait for a more appropriate skill or behavior that the child's doing and give their attention to that. And that might mean they're doing that at the same time. So they may be ignoring the fact that the child's whining, but using the pride skills to praise the fact that the child's still playing with the toys. They're still building a tower. And so in that way, we would start to shift the child's behavior back to the more appropriate play. And the child isn't getting reinforced with parent attention to those mild or negative behaviors. Now, during PDI, caregivers are learning how to set limits, as I mentioned, and how to be really consistent and clear with their expectations for their child. So we first start with, how do you give very clear and specific instructions? How do you give effective commands to your child that really support and increase the likelihood that the child's going to listen and understand what you're telling them to do? So we focus on the fact that these commands should be clear, simple, developmentally appropriate, direct, and worded positively. So we hear this a lot of no, don't, stop, quit from parents, especially when there are children with disruptive behaviors. We teach parents to instead word their commands in the positive in terms of what you want the child to be doing. So instead of stop climbing or stop jumping on the couch, we would say, please put your feet on the floor, or please sit down. So teaching the parents how to give these very specific commands, and then also how to praise every time the child is listening. So how to give labeled praises, thank you for listening, to compliance. We also focus on giving children an opportunity to comply. So we do tend to see, especially in the beginning of treatment, a lot of rapid fire commands. So clean up, put this in the box, clean up, come on, let's go. So again, very vague, but also rapid fire commands, and not really giving the child an opportunity to comply. So we teach parents to kind of slow it down a little bit, give a specific command, wait 5 seconds. They're counting that in their head, not out loud. And then if the child hasn't complied in that amount of time, repeat the command in the context of a warning statement of what that consequence will be if the child continues to not comply. And in Pcit, that consequence is a timeout. So it's a brief timeout for non-compliance. It's 3 minutes and 5 seconds of quiet. So we want to make sure the child is calm and regulated by the end of that time. And we teach parents to use a very specific script each time. So parents don't need to question what to do or what to say in these moments, and children don't question whether parent really means it this time, or do I have a choice, or can I wait? When they hear these types of commands and this specific script, like the warning statement, if you don't put your feet on the floor, then you'll have to go to the timeout chair. It makes the process really predictable and clear for children as well as parents. The timeout sequence only ends when the child complies with the original command. So in this way, it's not an opportunity to escape the initial command. Rather, it's a brief pause in what we're doing, which is play initially in the sessions. So a brief kind of timeout from that positive attention that they were getting through the pride skills and that engagement in the play activity until they're ready to comply. And we do also teach parents to use these direct commands very sparingly. So to only use them when they need it, when it's really important that the child complies in that moment. And so there's a lot of kind of metacognition that happens with the parents with this. We're really slowing things down and thinking about, Is it absolutely necessary that you give a command in this moment? If not, let's use choices. Let's ask a question or give a suggestion. Use a first then statement. We can rely on a lot of different parenting or other strategies. But in the instance that compliance is really, really important, with safety commands like holding your hand when it's time to cross the street, then we use these direct commands and we teach parents and children this process to increase compliance to those direct commands. And we start with very, very simple commands. So we use kind of like a shaping procedure through teaching this process, where we're starting with commands that are likely the easiest for children to comply with, and we gradually increase to more challenging real life commands and generalize even outside of the clinic to commands in public settings, command with siblings, and other situations. So I did mention timeout. Timeout, sometimes I get some pushback from parents and providers on this. Timeout has gotten kind of a bad rap in the media sometimes, and more kind of recently. However, research really does continue to show that timeout, when it's being used correctly, isn't detrimental to children's well-being. Timeout is a widely used child discipline strategy, and one of the strategies currently recommended by the American Academy of Pediatrics. In Pcit, timeout is based, as I mentioned, on a removal of positive reinforcement, such as social attention and access to physical objects. And there really is only one component of Pcit. So it's used in the context of a much larger set of strategies that include building a warm and supportive relationship between the child and the caregiver. And we teach the child or the caregiver first to use positive reinforcement and selective ignoring to manage behavior. And only if those strategies have not been effective to then teach them timeout and use timeout in, again, those very selective situations. So parents really aren't taught this timeout procedure until they master the other parenting techniques. Okay, and I'm happy to talk more about this. There are a lot of position papers that have been developed from Pcit and a lot of research that can support its use. That said, I have had families that just aren't willing to do timeout as an option for discipline, and that's fine. We work with them with the first phase of treatment. We teach them all of the other behavioral parenting techniques, and we talk about other parenting strategies that they may be able to use, instead of timeout. But I do want to move now to talk about the research examining Pcit with ASD, and specifically using this entire package of Pcit, including the timeout procedure. Now, Pcit and ASD research is limited, so there's the caveat. So it's really just started emerging in the past 10 years or so. This is the list of published studies to date. That said, we do so a lot of them have been case studies, but we are starting to see a lot or a growing number of larger studies with more experimental designs. And the research so far is definitely promising, as I'll go kind of forward to summarize. So some of the things we're seeing is that a lot of the improvements that we see at the end of treatment, and this is standard traditional treatment for Pcit, are very similar to those that we've seen in the 50 years of research of Pcit and neurotypical children. So some of the things that we're seeing are reduced rates of problem behavior. So the scores on behavioral difficulties, behavioral challenges, move from the clinically significant level into the non-clinical range by the end of treatment. We also see increases in child compliance with demands for the children with ASD, enhanced parenting skills. So parents are learning the skills, the Pcit skills, and we are also seeing decreases in parent stress. And also some studies have reported improvements in other areas associated with core symptoms of ASD, such as social awareness, language, adaptive skills, and shared parent-child positive affect. Now, the bulk of these studies really have been, or the initial work was done with children who were quote unquote high functioning, or children with mild ASD symptoms and average or above average intellectual and language skills. There are a few published case studies so far of young children with ASD and more severe developmental delays who have limited language and cognitive functioning, who may be nonverbal. However, with children with that type of presentation, we would, and the research, the published guidelines so far, have used an adapted protocol where we're not moving to a timeout procedure, but we're moving into what's called a compliance training procedure. And our group is doing this at UM, and we've seen about 15 cases so far where we've used this modified Pcit program or protocol. And we're going to be presenting our information that we've gathered from treatment with these children in the upcoming Pcit International Convention. And hopefully we'll add to the published research very soon. So while it's encouraging that these studies are showing very similar outcomes to those that have been shown in prior Pcit studies of children without ASD, no study until recently had directly compared children with ASD receiving Pcit to children without ASD in the same study. So our group took on that task and published a paper recently that has done that. So the purpose of the study was to evaluate whether children with ASD show a similar course of treatment and treatment response as children without ASD. So the treatment followed the standard clinic-based Pcit protocol. We had 32 families participate. 16 of those had ASD and 16 did not. And the children were matched based on their age, their gender, and the initial level of disruptive behaviors when they presented to treatment. These were children between the ages of 3 and 8 years. The sample was limited initially to children with an IQ and receptive language scores or standard scores above 70, who were not currently receiving other behavioral interventions at the time of Pcit and were English speaking. But our ASD sample did have a wide range of ASD symptoms, so ranging from mild to severe, and a fairly wide range of IQ, ranging from 70 to over 100. Okay, so what did we see? Well, first we found that the length of treatment, the compliance with which parents showed when doing the homework each week did not differ significantly between the ASD and non-ASD group. And we also saw that the parent and child outcomes did not differ significantly between groups. So both groups, initially, both groups showed improvements in the Pcit top parenting skills. So children or parents of children with ASD and parents of children without ASD showed an increase in those pride skills and an increase in their ability to use effective commands and follow through consistently with either praising compliance or the timeout procedure as needed. We also saw improvements in the level of parenting stress that parents were reporting from pre to post treatment. And we didn't see a statistically significant difference in the trajectory or the decrease of parent stress between the two groups. Although you can see here that interesting parents of children with ASD had slightly less stress at the beginning of treatment, although that wasn't significant. And both groups declined to the non-clinical range by the end of treatment. Now, I want to show you, and I think I'm doing okay on time, a little bit of what this looks like pre and post and what Pcit looks like as well. So here is a video of David. So David's father gave us permission to be able to show this. He was a 4-year-old male with autism. So just some kind of basic information about him at treatment or when he presented to treatment. So his ADOS total score was above the autism cutoff, and he showed a high severity level of ASD symptoms. His IQ standard score was 79. Parents reported symptoms including difficulty following directions, easily distracted, tantrums and aggressive behavior, repetitive motor movements, difficulty adjusting changes in routine, preference for playing alone, repetitive play, limited eye contact, and sensory seeking behavior. This is what David looked like at the beginning of treatment. Now, at the beginning of treatment, we do what we call a Dpx assessment, where we ask the parents to engage in a play situation with their children for 5 minutes when they're letting the child lead the play, 5 minutes with the parents trying to lead the play, and 5 minutes of cleanup. So this is the cleanup situation. So Dad is trying to get David to clean up the toy.
I got to the bed now. I got to the bed now. I got to the bed now.
Okay, come on, clean up. Let's go.
Okay.
Come on, start cleaning up.
Be careful. One to be careful.
Start cleaning up. All the toys, come. Can you put the train pieces back in the train box? Put the train pieces go back in the train box. You can put that in there. Put the trains in the train box.
In the book of please.
All the tracks.
Put it there.
Okay. Go ahead.
Mommy put the train there.
No, that doesn't go in there. That goes in the train box.
The book of put. Look at TVs.
Go ahead and clean up.
Where?
Come on, we're not done.
Where?
Come on.
Where? It's the.
All of that goes away. Put it away in the box.
Okay. So you can see with David, he is, not actively non-compliant. He's not, defying Dad's instructions. He's trying to clean up, but it's taking a while, and you can see how hard Dad's working, right, to get him to do that. So he's repeating instructions. David's losing attention. He's not, following the instructions of where Dad wants him to put the toys, and it just seems like a very effortful activity. So this is a video of David and his dad in the middle of treatment. So we had actually just had only one session of PDI where we're teaching the command sequence and the timeout sequence. And this is Dad and David engaging in play. And you'll see Dad delivering a command and going through that sequence with David.
Straight.
You're all great. You're all great.
I like the Lego card you built. It's very creative. You put a flower on top of it. I want to build a Lego house. Please give me the Lego, the green Lego.
Lego.
David, if you don't hand me the big green Lego, oh, thank you for listening. Thank you for giving me the Lego.
Okay. So you see that process, I know it's slightly different activities, but the process was very different. So Dad really is taking his time, thinking about what he wants to say, and giving a clear, specific command. And you could see that David had a little trouble understanding that command at first. But Dad waited, gave him an opportunity to kind of process it. And then when he realized he still needed a little extra help, went to the warning statement, which more often than not serves as an extra opportunity for parents to be more specific in their commands and an extra opportunity for the child to process and understand that command. And you can see David did it right away. And he had to stop kind of what he was doing, his preferred play with his toys, to follow Dad's instruction and do that right away. And this is typically what we see at the end of treatment, not necessarily after only one PDI session, but both Dad and David were very quick learners. Oh, let's see if I can get through to the next slide. There we go. So in our research, we also saw that both the children, or the group with ASD and the group without ASD, demonstrated significant and clinically meaningful improvements in child disruptive behavior and externalizing behavior. So you can see here the ASD group, again, is kind of in yellow, and the comparison or non-ASD group is in green. They're both, as a group, the score of disruptive behavior was above the clinical cutoff and clinically significant at pre-treatment. By the end of treatment and post-treatment, they were well between or well within normal limits. And actually, we hit within normal limits at mid-treatment. So just after the CDI phase alone, just through those positive parenting attention strategies, the pride skills, we're seeing the decrease in disruptive behavior, the intensity of disruptive behavior as reported by the parents, come and hit that within normal limits level. We also saw an improvement in executive functioning. So some of the skills that Dr. Udine was just talking about that are extremely relevant for our ASD population. So both children with and without ASD were scoring in the clinical range at pre-treatment, and both groups showed a decline in clinically significant decrease in executive functioning difficulties by post-treatment. And there is no significant difference between the two groups. All right, so I want to show you another little clip. I think I've got about 5 minutes or so we'll try and get through this. This is a video of Jack. So Jack was 4 years old also when he presented to treatment. Primary concerns for Jack were a little different. So he was demonstrating more mild symptoms of ASD, but more significant oppositional and disruptive behaviors. So we also demonstrated aggressive behaviors, hitting, throwing toys, and significant emotion regulation difficulties. So he was very quick to anger, had trouble calming down when upset. So this first video shows the Dpx initial assessment. We're just giving the instructions for the child to pick what he wants to play with, and the parent follows along. So really, really low demand. I will warn you, the volume may increase, so you might want to have your button on your volume to turn it down a bit if needed.
Real leaf?
Yeah.
This is a bear.
All right, Dad, in this situation, tell Jack that he can play with whatever he chooses. Let him choose any activity he wishes, and you just follow his lead and play along with him.
Okay, Jack, I'm gonna let you pick the toy to play with. Well, pick a toy first, and after we pick toys and play for a little bit more, we can go home and get something to eat.
And we just lost sound from Dad. I swear I tried these
Well, pick a
videos
toy
multiple
first, and
times
after we
before
pick
this
toys and
session,
play for a little bit
so
more,
I
we can
will
go home and get
narrate.
something
It
to
happened, I
eat.
think, the last video too, but I thought I fixed the
I'm
problem.
gonna let you pick something to play
So Dad's
with,
just telling
alright?
Jack, you can pick whatever toy you want. And he loses it. He just starts crying. That kind of intensity of cry increases. You can see it in his face there. And then, oh, you can hear the video. Okay, I'll stop narrating. I can hear it. And the toys are on the floor. Okay, I'm gonna stop it there. To Dad's credit, he stayed so calm throughout this, and that's kind of telling too. I think he's used to these things happening quite frequently. But so parents, both actually parents participated in treatment, and treatment lasted about 17 sessions. And this is at the very end of treatment. So this is Jack and his dad in another play situation. Dad, you'll see, is using a mix of pride skills and a mix of commands, but it looks very natural. And just Jack is responding very differently.
How did you find the heart eyes? That's a great find, buddy. That's a creative idea.
I
I like when you
video
get
too,
creative
because
with,
I cannot.
with the things that you choose for your Mr. Potato Head. My Mr. Potato Head is missing a tongue. Please hand me the tongue. Thank you for listening, Mr. Jack. I like when you listen. He is sticking his tongue out at you now. I need another arm for mine. You're putting a blue hat on your Mr. Potato Head, and now you need an arm.
You have the big arm. I need the big arm.
Here's the big arm. Nice job asking me in a very calm voice. And
The arm
being
goes
flexible.
on the bottom.
I like sharing.
Can you help me put this in?
The arm does go on the bottom,
Stop
and
it
you did
there,
a
I
great job
think.
of asking.
So very different, right? He's sitting calmly, he's listening, he's sharing, being creative and flexible and calm. And you can hear Jack's father giving attention to all of those things through the use of the pride skills. He likes when he listens, he loves sharing with him, he appreciates when he asks for things with a calm tone of voice and his words. That is the power of Pcit. And it was really one of those transformative changes with Jack in particular, and this is very common to what we see in Pcit in general, and what we are seeing with our Pcit and ASD kids as well. I think it's the video until I get to the next slide. Okay, I only have a few left. So one of the remarkable things that we saw as well in our research was if we look at the ASD group alone, we saw some really important improvements So PCIT is an intervention that's focused on disruptive behavior and compliance, right? That's what it is developed and what it aims to treat. But it does that through the use of these pride skills. And we are really tailoring the approach to the use of PCIT to the individual child. So we are specifically targeting behaviors that are meaningful for that child. And so it's not surprising that we are then also seeing other behavioral change within the context of PCIT. And for the children with ASD group in our study, we looked at that 16, that group of 16, we saw statistically significant improvements from pre-treatment to post-treatment in social awareness, in restricted and repetitive behaviors, in adaptability, that flexibility, being able to change and adapt to different things and demands in their environment, in social skills, and in activities of daily living. That's if we look at the ASD group as a whole. If we look at individual children and whether or not they were what we call treatment responders, did they show a meaningful and significant change or response to treatment? We see that about 30 to 50% of children with ASD did show clinically meaningful improvements in these measures as well. So this study that our group did really replicates and extends the prior research by demonstrating that children with and without autism experience similar benefits following PCIT. And while the results suggest that the majority of children with ASD show excellent treatment response in these in the traditional PCIT outcomes, we do see that this small subset of children are also experiencing clinically significant amelioration of ASD symptoms. Now, it's not surprising given the variability of the symptom presentation and severity in ASD. The heterogeneity that we see in treatment outcomes is also well known in the field of ASD. So we don't expect to see 100% treatment responders to this one intervention. ASD is very heterogeneous. And so I think that the field now is trying to tease apart what those variables are that would predict a child to be a treatment responder in PCAT and other interventions. So that's definitely an area of future direction. So as I wrap up, I want to leave you with one more video, and then our kind of summary points. This is a video of a very different child. So as I mentioned, that we are also doing PCIT, an adapted or modified PCIT protocol for children who are nonverbal or exhibiting more significant developmental delays. So this is Aiden, and pre-treatment, he was not using clear single words. He vocalized infrequently. He didn't have any use of compensatory strategies, either no sign language or AAC. Parent concerns included behavioral outbursts, aggressive behavior, self-injurious behaviors, and limited communication. And this is what Mom and Aiden's play looked like at the beginning of treatment.
What's this? You feel some tickles? You feel some tickles? Look, Papa. Look. The little sheep. Aiden. What's this? Yeah, a bunny. Yeah.
Okay, I'm gonna stop it there. All right, so you can see that Aiden is largely turned away from Mom. He's engaging in repetitive behaviors. Even when she gives him a toy, he kind of wanders around and isn't really using that toy functionally. This next video is mid-treatment. So in CDI, just using those pride skills and parent attention alone, imitation, reflection, and praising.
Yes, you did a good job opening and closing the race car set. Yes. Oh. Yes.
See that shared eye contact.
This is a really cool set. Open and close. And pick
question.
Good job. That's the tractor. Oh, good job opening that up, Avi. That's awesome. You're so good at that. Wow.
Okay, we'll stop it there. So you can see functional play definitely increased from the beginning to the end of treatment. And again, this is just mid-treatment that we're seeing. Mom's ability to follow his attentional focus, to engage with him, even when he's engaging in behaviors that wouldn't clearly be communicative or not obviously. But she's entering his world and entering kind of him at his level with those behaviors through reflecting, through describing, through talking about the play, and reinforcing those behaviors. So we definitely saw a remarkable change with Aiden as well. So just to kind of wrap up and summarize, so some of the points I'd like to kind of leave you with today are the pros of Pcit, and the reason why Pcit could be a viable treatment option for children with ASD is it's effective short-term strength-based treatment for young children with behavioral challenges. There are over 300 publications with various populations, cultures, and ethnicities, diagnoses, formats, and delivery. And the research base for children specifically with ASD is growing. We use objective, data-driven criteria for treatment progress. The parent and the child are seen together for all but those two teach sessions. We're providing parents with live coaching and immediate feedback. So every week they're given the opportunity to practice these skills over and over again and really tailor them to their child's individual need. We have very high client satisfaction, and that certification process to assure that the therapists really are delivering the treatment in the way that it's meant to be delivered. Now, some things to keep in mind, however, is that Pcit is intensive. It does require a high commitment from the parent and caregiver as well. And the research with ASD specifically is limited, but growing. It does require modification for children who are more impacted. And it does, we don't have good research to suggest this yet, but I would say at this point in time, it would probably be beneficial to work with a Pcit therapist who does have some how to really tailor the treatment to their needs. And so Pcit, again, it is really focused on improving compliance in those disruptive behaviors, so it's limited in scope. And it may not be the primary or only treatment needed for children with ASD. In fact, it likely won't be. But it may serve as a possible gateway intervention. So it may serve to prepare the child for more intensive therapy by serving as that necessary primer that enhances the parent-child relationship, increases child compliance, and therefore setting the stage for greater success. In some cases, this intervention might be sufficient, or at least a more feasible option for families who don't have the resources to invest or even access more of the services. And so while Pcit may not necessarily replace the other intensive treatment options for children with ASD, like ABA or the other NDBIs, it can offer direct support to parents and children in addressing their complex needs. And really, the last message I want to leave you with is that it really never hurts to strengthen that parent-child relationship. And in fact, that might be the most important thing. So if you want to know more about Pcit, there is a Pcit International website where you can look at some of the literature, research, measures. You can find a certified therapist near you. So if you aren't in the Miami-Dade area and can't access our program for free, there are other certified therapists available, and this would be a great way to search that up. If you are in Miami-Dade and interested in being screened for our program, you can go online, and I believe that the flyer was in your handouts today. So I think that's it. I will look at the Q&A, and I will be around at the panel later to answer any questions you might have. Thank you for your time and attention.
Thank you, Megan. That was great. You do have a couple of questions on the Q&A chat. So if you have a little time and you want to go ahead and answer those before the panel, you can certainly go ahead and do that. Thank you. Thank you for everything you're doing at the University of Miami.
Thank you.
Just a quick note before we go into our next presentation. We'll have Dr. Gutierrez share his screen here in the meantime. I just want to let everybody know that if you have questions, put them in the Q&A. We've done a pretty good job of answering many of your questions already on the Q&A as our panelists have stayed on the call. So they've been able to answer many questions that are in the Q&A box. We will still have a panel discussion at the end of the day. So we'll be able to do that. And you'll have access to most of our panelists there if you want to continue to ask questions in the Q&A box. So we'll move on. Our next presenter is Dr. Aníbal Gutierrez. Dr. Aníbal is a professor at the University of Miami. He's also an associate director at CARD. And he's the director of the IBIS Clinic, which is a behavior clinic at the University of Miami. He'll be presenting today on mixed reality and applied behavior analysis intervention. Dr. Gutierrez, you're on.
Thank you, Louis. I hope you can hear me and see everything correctly. Is that right?
Yes, you're good.
All right, great. So thank you, guys. I'm really happy to be here. And I'm excited to talk to you about something that is a little bit different than what I usually talk about when I talk about behavior analysis. So I'm going to be talking about technology and specifically mixed reality and applied behavior analysis intervention. This is kind of a new area. We've got some internal funding from the University of Miami, which we're really grateful for. And I'm really lucky that I work with a team of collaborators who are just infinitely smarter people than I am. So I'm really fortunate for that. So we've got people working on this team from the Department of Electrical and Computer Engineering. We've got folks from computer engineering, interactive media, and I also have a colleague, Dr. Leon, in the Department of Psychology. And so I'm going to talk to you today a little bit about technology, generally speaking, in behavior analysis. And I'm going to talk about some of the things that are out there beyond the more basic technology. And we're going to get into virtual reality, augmented reality, and then mixed reality. We were in the process of launching some of these projects right when COVID started. And so unfortunately, I'm not going to be able to show you a lot of great examples or great data because we were not able to recruit and run subjects for obvious reasons. But it's looking like things are hopefully improving a bit. And so we're going to hopefully get started with some of these. So I'm going to tell you about the technologies and I'm going to tell you about the projects that we plan to start. So as you guys probably know, applied behavior analysis interventions have been shown to be effective for individuals with ASD and a variety of studies for many years now. And this intervention is often delivered in small group or one-to-one settings, one therapist to one child working directly and intensely for many hours. And that's extremely effective, but it does result in a high cost in terms of manpower, training those therapists, and those hours are costly because of all the folks that are involved. And so we've been looking for a long time towards technology as a way to potentially decrease some of that cost, but also increase access to services. You guys probably are aware that a lot of people are waiting for services. There just aren't enough therapists to go around. Now, I'm not suggesting that we're going to replace the therapist. I'm not suggesting that we are going to, sort of make it such that you no longer need an ABA therapist. Not at all. What we're kind of suggesting here is that we're going to increase access and maybe create opportunities where folks could be receiving intervention rather than waiting for intervention by just opening up the doors a little bit through the use of technology. And so, a lot of you are probably familiar with some of the things that are out there, like video modeling interventions, maybe some of these interactive applications and games. In fact, I'm an author on a lot of studies on video modeling. And that, what we know about that is that it is a well-supported intervention. It's been used to improve a range of skills: communication, perspective taking, community skills, even problem behavior reduction. And video modeling, this is where we show video examples to individuals and ask them to follow that example, has been used across a range of ages and functional levels. It's a relatively cost-effective and time-efficient. So there are several studies showing that that use of technology is effective. But as much as I am part of that group evaluating and demonstrating the effectiveness, that use of technology is relatively low tech in the grand scheme of things. And so we are able to, to look at the limited potential that has in terms of interaction and in terms of giving opportunities for learning and interaction. And we can now look towards other technologies like video modeling, like virtual reality and augmented reality. And together, those are referred to as mixed or extended reality. And those have the ability to allow interaction with the natural environment. And that's an important thing to consider, because those may be the things that really let us harness the power of behavior analysis. If we can get technology that lets us create these learning opportunities where the individual is able to interact with the environment. And so, when we start talking about these technologies, it's important for us to get our language straight here. So let's start with virtual reality. When we talk about virtual reality, we're talking about putting on one of these sort of headsets, and that involves this simulated experience that can be similar or completely different from the real world. So virtual reality allows complete immersion experience that can shut out the physical world. Some examples that you may have seen include the virtual reality. The HTC Vive is one version of these headsets that you might see out there. The Oculus Rift, you may have heard about those, or maybe even Google Cardboard, sort of a low effort kind of little box where you put your cell phone and you can then view an immersive environment and have an immersive experience. So those are really interesting, and those are probably the ones that maybe some of us are more familiar with. And those virtual realities, because we have this simulated experience that can be completely different from your real world, you can really shut out the environment that you currently find yourself in and create this completely new environment. Now, sometimes that can be really amazing. And you can then create these nice, clean environments in which people can experience completely different settings. So here's some images showing what some of these headsets might look like. You may have seen commercials about this. So those are really fun and popular. And I think that if you've heard anything about virtual reality, or maybe you know a teenager, you may have heard of probably the most popular version of virtual reality, and that's called Beat Saber. So I'll give you a short video clip, and this one has no sound, so don't worry. And in this one, you'll see that what the person puts on the headset, they find themselves in a completely immersed environment where they play this game. Pretty engaging, pretty fun. If you play Beat Saber, it's completely immersive and you sort of forget where you are. So that's just a little example of what a virtual reality environment could generate. And so what people have started to do is they started to take this vehicle, this opportunity, this technology, and start creating environments where maybe we can perhaps teach a new skill or experience a new skill. And that's one of the things that we have done, is we have collaborated with some folks to develop virtual reality as a teaching tool. And where we started with a application that would teach you how to make a hamburger. Sort of simplicity and what was available to us, we figured we would start there, and we would evaluate the utility of putting on a headset and experiencing a completely virtual environment in which you would be taught how to make a hamburger. We wanted to evaluate that with a typically developing population to test the acceptability and the comfort of it. And then our plan is to then take that forward and evaluate the use of that technology to teach individuals with autism how to use that technology and potentially learn a new skill. And of course, we're going to use the vehicle of making a hamburger. Now, the video I'm going to show you here is just a little example. It's not our application. I wasn't able to get that extracted for us. But here's sort of an example of games that are available out there in virtual reality that let you kind of experience this game version of making a hamburger. And so you can see that the individual is sort of looking at instructions on the screen in a game format. They, grab the materials. They can grab the plates. You can, of course, throw them around. You can grab the plates, and you can start to put the burgers, the patties on the grill, and the buns together, and so forth. Start to create these hamburgers. Now, outside of the cuteness of it and the fun aspect of it, I think the important part for us is to realize that from a learning perspective, this may create an opportunity where an individual is able to walk through a task that they potentially have never done before in an environment that they've never been in before, and potentially learn how to do something that they don't previously know how to do. And that's the way that we're looking at virtual reality as a tool to potentially help us create these environments without having to physically set up a kitchen, get the materials, prepare the food, bring the food, store the food between sessions. So from a training and from a research perspective, these VR tools offer immense opportunity in that they eliminate a lot of the logistics of carrying out training sessions. So we see a lot of potential in our ability to use these technologies to accomplish some of these things. Also, we're able to conduct these sessions in an environment where no one is risking burning themselves or hurting themselves with any of the equipment. And so you might practice some of these steps without all these considerations. Along those lines, I've been working with a student to develop something more geared towards younger children with autism, just as a trial version. Again, this isn't intended to replace anybody's ABA therapy. We're just looking to evaluate if these things could in fact be done. And I want to show you a little bit of a video here. So give me a second while I sort of transition here between screens. The video is, let's see, I believe that this is the one. The video is, give me 1 second, I'm sorry, I'm struggling to grab hold of it here. So this is an application intended to teach discrete trial skills. So here we're teaching this is an example of an application where we're using it to teach animals, discrimination between animals.
Welcome to DT Love. Ready?
So that's just an example of the application that I've been working on with a student at the University of Miami. And it's just the basics, the building blocks of something that we think could be expanded, could be tested, and used to see if we can sort of leverage this technology to create learning opportunities outside of maybe your regular ABA session. Again, not intended to replace anybody's therapy or anybody's sessions, but while maybe the teacher or a therapist is busy with another child, potentially someone could put on the headset and almost engage in homework, activities that they could accomplish on their own. Again, I'm not suggesting that we're going to replace what we do in regular therapy, but this is a way to kind of use technology to augment some of that therapy and provide greater access. And so once we, sort of think, okay, there's a lot of limitations to this virtual reality. I don't really want to be in a fully immersive environment. We can then also look to a different technology, similar, but it's different. It's called augmented reality. And in augmented reality, we have a live view of a real world environment where we merge elements with computer generated imagery. And so what we do in augmented reality is we pop in information about the surrounding real world that can become interactive. So there's some information out there that we can add in through these screens, and we can add cues or make the world a little bit more informative. Probably the first version of this that some of us are familiar with, we may have seen, the little videos of Pokemon Go, where you take your screen and you sort of walk around looking for these Pokemons, right? Probably seeing this at the bottom right corner here, where people interact with their smartphones and they hunt for Pokemons. I know that my kids were certainly into it. And that was, I think, a very broad introduction of augmented reality for a lot of us. Now we can look at other examples of augmented reality where it's a little bit more practical. This is maybe something that some of us might be interested in. Here's a video showing the use of augmented reality for not hunting Pokemons, but maybe fixing issues with your car. And so in this video, you'll see someone holding up an iPad and looking at their car, under the hood of their car, and augmented reality is being used to drop in information and cues to guide someone how to complete a task that perhaps they don't know how to complete, or give information that they maybe aren't expert in. And so a person who doesn't know a lot about cars could use this augmented reality to augment, enhance, expand their understanding of what it is they're looking at. And so here, this person is sort of being guided to open up this little twist cap and then add oil to their car. And so again, from our perspective, we're looking at this technology and saying, wow, could we use this to add cues, to add prompts, to add SDs from an ABA perspective? And could I use this augmented reality technology to potentially walk someone through a task that they previously did not know how to do? Of course, I'm very, very excited about this. And so with a team of engineers, we've been working with a headset, and the hardware is called the Magic Leap hardware, where you would put on a set of glasses and you can still see your environment around you, but those glasses can be used to drop in cues and drop in information into your real environment. So what I'm going to show you next is a video of an application that we have developed to, again, walk you through the task of making a hamburger. We're just sort of stuck on this hamburger thing because that was what was available to us. So we're just going with it. So a lot of the examples you're going to see are about hamburgers, not because I feel strongly about the fast food industry or burgers in particular, but that's just what was available to us. So I'm going to show you this video. And this one does have sound.
Place the prep table. When you are ready, aim your control at the floor and pull the trigger to place the table. Great. Now let's learn the controls. Your controller is now a virtual hand. You can grab interactable items by moving the virtual hand over an item and then pulling and holding the trigger. Go ahead and try grabbing the bottom bun. Now place it on one of the plates on the counter to proceed. All right, I will assist you in making your burger. You can also check the display on the counter for the steps to complete your current order. Our first order is a hamburger. Go ahead and place a patty on top of the bottom bun. Great. Place lettuce over the patty. Great. Place tomatoes over lettuce. Great. Place onions over tomatoes. Great. Add some mustard sauce. Great. Add ketchup. Great. Place the top bun. Great. Your burger is done. Ring the bell to call the customer. Great. Look in the eyes of the customer and hand over the burger. Great.
And so, what you were seeing there is you were seeing this headset dropping in all these virtual stimuli into your real physical environment. So again, we can start to think about how can we leverage these technologies to help us learn a new skill from the standpoint of ABA. How do I teach someone how to do something in the most effective way? So we're really excited about this one. We developed this one to sort of match up to the virtual reality version of this so that we could evaluate the use of virtual reality. We could evaluate the use of augmented reality and see if any of them had any benefits over another. I mean, there's arguments for why a fully immersive virtual reality might be better than an augmented reality. And then you look at an augmented reality and say, well, that can be done in your natural environment and we can drop in cues. Would that be better from a generalization perspective? So there's a lot of really interesting applied questions that we're going to be pursuing. So this app it exists. It exists in the Magic Leap headset. And we're ready to go with it. Once the COVID restrictions allow us to proceed, we're going to start running, again, non-ASD, typically developing individuals to tell us and give us some feedback about, how it works and how it feels. We'll do the same with individuals with autism. We'll bring them back in, get them to tell us how it feels. Do they like it? And then we'll also try to evaluate, could we teach a new skill using these technologies? So we're really excited about this. We can't wait to go. We've got all this great equipment and all this great software just ready to go. If we could just get through this this pandemic. And then finally, this kind of takes us to the last step where we're getting at here, and that's called mixed reality. And so in mixed reality, what we have is a blend of physical and digital worlds, similar to augmented reality. But what we do is we create this hybrid where physical and digital objects actually coexist and interact in real time. And so in augmented reality, the cues were just sort of dropped in. But here in mixed reality, the digital components become part of the real world and they interact with the real world. So for example, in this bottom image here, you can see that someone's sort of being instructed to turn a wrench. And as that wrench is turned, the physical cues move with it. And maybe they count how many times you've done it, or they start providing some feedback to you. So it's a little bit more advanced version of augmented reality, what we have in mixed reality. And mixed reality is the part that we're sort of looking currently as kind of the last frontier, where it really takes a little bit more tech to get us there. But that could really be the place where someone could put on a headset and could be walked through a variety of different tasks with a lot of feedback in real time, and could really start to provide us with some really, really neat opportunities for teaching and supporting not just individuals with autism, really just typically developing individuals, but of course we see from our lens a particular benefit here to individuals with ASD who need a little bit more support. I'm going to show you a little video of one of these techs. It's called a Holo Lens, and this was made by Microsoft. And I clipped this video, and it doesn't have any sound, so that I can kind of walk through the video with you. So the Holo Lens for mixed reality is a Microsoft product where they're trying to create this hardware that will allow us to create software that will allow you to interact with a digital environment in real ways. And what I mean by that is that you'll be able to look at items in 3D. You'll be able to interact and see how things work and see how things sort of happen. And it'll give you feedback right away. So it isn't just overlaying cues on it. You actually get to interact with those cues in real time, which I think it really has the potential to be really, really something that changes the way that we do our work in very meaningful ways. And so the potential for intervention that we see is that this mixed reality, where we take real physical environment, we overlay the virtual information, and we deliver this two-way feedback where they actually become part of your environment, has, from our perspective, the basic foundations to provide teaching and training within an ABA framework. And so when you stop to think about what is an ABA framework, ABA framework is just giving a learning opportunity. You're going to present an antecedent, you're going to present some prompt or cue, and if the behavior occurs, you're going to deliver a reinforcer. That's the basic unit of learning. And this is not something that just people in ABA do. All parents and teachers who teach anybody anything are really doing these strategies. And so from the basic foundation of framework of ABA, these mixed reality give us these natural environment opportunities that will, number one, promote generalization. If we can deliver cues and prompts, we're going to potentially promote independence. We're going to remove the need for a therapist or a parent or another adult to be with you, providing you cues and prompts the entire time. We're going to be able to put these on board of a headset that could potentially let you be a little bit more independent. And we're going to be able to deliver reinforcers, tell you, yes, correct, you did that correctly, and promote skill acquisition, again, while fading back the need for a physical therapist to always be there with you. And so, in sticking with our burger theme, we are developing a augmented reality app that will involve computer vision. And I'll explain what that means in a little bit. And again, we're going to evaluate this with a non-clinical population to test the acceptability, but also we're going to take this non-clinical population and we're going to try and teach them a new skill using this headset. And we're going to then move on and evaluate whether we can do this same thing and teach individuals with ASD new skills using this technology. And so we have what the images that you're seeing here on the right there are actually some burger pieces that we had an artist 3D print and paint for us. Again, this is just a logistics thing, but how do you conduct these sessions without constantly having to prepare food and, chop lettuce and fresh tomatoes and buns? So we had some of these things 3D printed for us so that we could get around that, that logistics issue. But they're beautiful. They look really, really nice. They are stackable. And so we would be able to walk someone through actually interacting with physical components, being guided with a headset that provides virtual cues for you. And so in order to go beyond that static training situations, we're going to need a system that could adapt to real world situations, because now we're going to require that the headset see what you're seeing and recognize what you're recognizing, and understand that this is a bun, and understand that this is a piece of tomato, and where's the lettuce and where's the ketchup, so that it can prompt you to do these things. And for that to go beyond and really get to the potential of mixed reality, we're going to need computer vision and we're going to need artificial intelligence. And I know that these sound like maybe science fiction kind of terms, but to our engineer colleagues, they're just what they do every day. Thank God for them. And so computer vision is when computers are able to acquire, process, and analyze digital and physical worlds. So this is actually a computer that can look at something and say, this is a hamburger bun, or look at something else and say, this is a slice of cheese. And then we're going to incorporate furthermore artificial intelligence. And what that means is this is the simulation of human intelligence in machines, but really the term is applied to any machine that exhibits learning and problem solving. So the artificial intelligence is the thing that's going to help us say what this computer is looking at is in fact a hamburger bun, as opposed to a hamburger patty. And so that artificial intelligence is going to allow us to look at new hamburger buns and different hamburger patties and still recognize them as such, so that the prompting and the instruction can really be flexible and can extend beyond our basic training settings. So we're super excited about that part. And so what we have then is we have this mixed reality as a teaching tool, augmented reality application with computer vision and artificial intelligence. And what we want to do is we want to take that and tackle these big problems. We want to evaluate the use of a non-clinical population for acceptability, but then again, also see if we can teach a new skill. And this is what we're proposing. We're finally stepping outside of making hamburgers, and we're going to try to teach a brand new skill. So we're proposing that we're going to recruit young adults to typically developing young adults who don't have a skill. And so when you think of what do a lot of typically developing young adult skills, what skill do they lack? Well, for a lot of young men, it might be doing laundry, just as an example. So we're going to work on an augmented reality application with computer vision and AI that's going to recognize the environment around you and walk someone through the task of doing laundry, providing prompts, providing cues, providing reinforcers. Yes, good job. Press this button, put this here, close the door, and so on. Then we're really curious to see if without any outside instruction, could we put a headset on someone and walk them through a task that they have never done using these basic ABA principles of prompting and reinforcement. We're really excited. We think that we can do it. And we can't wait to get past these restrictions so that we can start to bring folks in. And then we would, of course, then recruit, once we've figured out the ins and outs of this, we will then recruit individuals with ASD, again, young adults with ASD who maybe don't have this particular skill, and see if they can be walked through this task using this augmented reality application with computer vision and AI, where the system recognizes real environmental cues, and not just the training ones, a variety of ones, to teach these new skills. And that part, I'll be honest with you, I'm really excited about. I think it's going to be a really big challenge. But when I think about what we can do with this, when I think about the potential, again, not just folks with autism, for a lot of folks, but particularly I'm excited for individuals with autism, we could maybe develop and assist with mobility and transportation skills. If you could wear a headset that tells you this is the correct bus and get on it and tells you when to get off that bus. Now we have maybe a young adult with autism who has independence to go to the library or go to their job that they haven't been able to get to because they lack that skill. Could we teach and support employment skills? Could we teach a brand new skill and then support you in it every day? Continue to provide you prompts as necessary. That part is really, really exciting because, as we know, there's a lot of adults out there who are underemployed or just completely unemployed. And so I'm really, really excited about the future where someone could wear a headset and have the confidence and the support to go out and do this job and do it well and do it independently without needing for, a person to physically support them. And then finally, of course, safety and security. I mean, as technology improves, that's always been a thing that's coming along, but our ability to then sort of look out for difficult situations or tricky situations, I think is also really, really exciting. So, that part just really is a lot of fun for me. I'm really looking forward to getting to work on those things. And then, I'll sort of wrap up. I think my time's coming close to an end here. I'll show you my email address, and I'll give thanks to the U-Link group. They've been supporting our work, the Laboratory for Integrative Knowledge. They've been supported, and here's a link, a little story and a little bio about our work. You can reach out to me if you have any questions, and I'm happy to take a look here at the Q&A real quick as I stop sharing my screen and see if I can answer any questions in the last couple minutes that I have. So I'll stop sharing, and I'll say thank you to everyone, and I'll take a peek at the Q&A. Maybe there aren't any for me.
Thank you, Aníbal.
Thank you.
Thanks. Yeah, you do have a couple of questions on the Q&A, so if you could take a little time and answer those would be great. They're specific to your presentation. So
yeah, I can do that now. Thank you.
All right. Thanks, Aníbal. Before we begin with our final presentation of the program, I just want to mention that those folks, again, that have questions for our panelists that have not asked those yet, please go ahead and do so, as we are roughly, half hour to 40 minutes away from ending the program and beginning our panel. We have answered several questions already in the Q&A box, so I'm not sure how many additional questions we'll have for the panel, but most of our panelists are going to stick around for that panel discussion. And if you have any extra questions, they'll be available to answer those questions for you. So with that, we'll start with our next presenter. It's Sylvia Gill. She is the manager of our Daniel Jordan, Fiddle Foundation. She's a transition and adult programs manager. She works both in Broward and in Dade and does a lot of work with our adult population. And she has spearheaded the program that she's going to talk about here today, which is building community through the Autism Friendly initiative. So with that, I'll give it to Sylvia Gill. Sylvia.
Thank you, Louis, for that introduction. Are you able to see the presentation okay?
Yep, you're good.
Awesome. Well, thank you so much for having me. I know it's always really tough to be last, especially given all these amazing presenters. So thank you. I will try to be entertaining and quick. I know being the last presenter. So I'm really excited today to be sharing with you building community through our Autism Friendly initiative. This project is really close to my heart. I will share with you some personal stories and really excited to be sharing some words from even our partners. So as Michael kind of had mentioned, this is really one of those things that we started to see the impact when we kind of work together, creating those collaborative partnerships to build those inclusive opportunities and a lot of opportunities for all of our individuals on the spectrum. So why, what we'll kind of be talking a little bit about today is why Autism Friendly. So why did this kind of start? We're going to really look at the positive impact that we're seeing from this project. We'll talk about some of our mission, our values and goals, some of that specialized approach. And then again, really excited to share with you, one of our partners kind of created a short video to kind of really show putting the story all together. So we'll be showing you that at the end. So why Autism Friendly? So as you can see on the screen, this is my purpose. My beautiful, wonderful Addison and Aiden. Not only am I a professional and I work with CARD and I'm so happy to represent it, but I'm also a parent. I'm a parent of a wonderful kid on the spectrum, Addison, who's 7. And, I have experienced some of the struggles that many of our parents have shared with us. And it really all started when we were going to a museum and we were so excited to be sharing this moment and going to a birthday party. And as we get to the museum, has any parent ever been asked to put a bracelet on their child? So I'm sure many of you are smiling because we know that these plastic paper bracelets can always be a bit traumatic, especially given some of those sensory components. And as they asked me to put this bracelet, she cried. They wouldn't let us in the museum. And like any parent, I am completely embarrassed, trying to explain myself. We leave. And I stayed up all night and I was like, you know what? No, we're not going to leave. We are going to make sure that this doesn't have to keep happening. And so with it, I went right back to the museum and I said, let me tell you about this amazing organization, CARD, and how we can work together to really support any child that wants to experience your space. And so through that, I, started working with Young at Art, which has been a wonderful partner of ours. And we started to see that through this Autism Friendly partnership, we started to see that we were valuing everybody. We were celebrating their diversity, their individuality, creating some of the opportunities. And through that, the staff, other members in the community, we started to see more empathy, tolerance, and compassion. And then at the end, which is, of course, our ultimate goal, is that acceptance and inclusion. So really excited to share as a professional, as a parent, some of the impact that we've seen. And so how does this benefit you, whether you're a parent, a professional, therapist, a business owner? We're really going to start to look at how did this impact the individuals, their families, the business organization, and then ultimately the community. And so we started to see this positive impact, which was the ability to be integrated in the community. And we wanted to make sure not only are you integrated, but you're provided some of those appropriate accommodations and supports, as well as those social opportunities. If we're home all the time, how are we going to be able to socially engage and make new friends? And then we started to see that we were having opportunities for exposure to some of those new environments. And ultimately with the goal, and I know Anibal was just kind of talking about this, but employment opportunities. How does this impact you as a family? So for my family, it's really important that we experience our lives as a whole family unit. It shouldn't be up to me to coordinate a babysitter or split the siblings up and you go here and I go there. And really, we want to be able to experience life and she should be able to experience life just like any other kid. and assisting the individual to generalize these skills. So it's great that our kids are learning home, therapy, school, but we need to be able to bring that out into the community and practice some of those skills. Again, providing social opportunities as a family together. A big one is, again, and I just mentioned that, the reducing stress and anxiety caused by those past negative experiences. We've all abandoned carts and ran out of the stores, and we wanted to make sure like you have all these opportunities to now be able to make some new memories. And then again, having the tools, you can access these tools to create that positive experience. So whether it's those visual supports that we help create, those sensory bags, you as a parent or a professional can access that to create a more positive experience. And so how does it really affect maybe a business owner? And we want to make sure that they're playing a key role in making these families feel welcomed. And then also it really gives you a good image within your community. We know that really close to 12 million people are impacted by autism, are going to engage within your business. So not only expanding your customer base, but you're going to be able to actually provide that quality service that maybe most business owners aren't even aware of. So it's bringing that education, bringing that knowledge to create some quality service. And then ultimately, really, we would love to see more of that employing individuals on the spectrum. This isn't a charity case. This isn't for organizations to say, oh, let's help out those on the spectrum. No, our adults, and I'm very blessed to work with our adult population. They have a lot to give. They have talents. They have wonderful skills that are going to enhance a company's capacity. And then at the end, it's really affecting the community. So providing community members with that public awareness and education. Michael did share in the morning of, sometimes we're not aware of some of these traits, but if we can provide some of that awareness, so parents, when their kids are little, they can start looking out for some of those characteristics. We know that through inclusive opportunities, community members have a greater sense of empathy, compassion, acceptance. And then individuals on the spectrum can create positive contributions. So through some of these opportunities, we start to see some of those volunteer employment opportunities, and with the ultimate goal of building independence. If I'm an adult on the spectrum, I'm able to be employed. I'm able to maneuver my community because I'm welcomed into the community. I can then become more independent. So through all of that, through the observations, we started to really build our mission. I'm very blessed to work with some wonderful CARD colleagues to work on this. But really what we started to see is we wanted to collaborate with businesses to really create that compassionate, non-judgmental environments for individuals on the spectrum, again, and also related disabilities. I always say I never want a mom to feel you have to run out of the museum. I want you to stay. I want you to enjoy it, and maybe just enjoy it the way our kids enjoy it. And through that vision, we want to make sure that companies welcome all individuals so they can thrive in their social development, employment, and educational experiences. So what are the goals? We really want to make sure that we undergo a partnership. That's the key, right? We're finding partners that are just invested as we are. And we started to see there are so many amazing community members, I'll make sure to recognize in the end, that really were as passionate as we were. It's just they told me, Sylvia, I'm not really sure what to do. I don't know how to structure it. I don't know what the customer needs. And that's where we come in. We give you that training tailored to your specific organization's needs. And then we break down those goals. We understand that it could be very overwhelming to try to change and structure your company, but we really meet you where you're at. And then we're going to kind of break it down slowly so that you can attain those goals to make it a more inclusive environment. And then again, the biggest key is that collaborative partnership where we can always be welcome back. This isn't a one training and hey, good luck. This really is this ongoing collaborative partnership to continue these inclusive opportunities for every individual. And so again, really focusing on what are those values. It's the teamwork. We're not coming in to say, hey, what are you guys doing? It's, hey, let's work together to really create these opportunities, really providing some of that quality training, and building that critical partnership, and really having some personal accountability. So making sure if you are one of our partners, we really want to make sure you're really performing, again, with that quality that we give you that support. And so through that, we really have our guiding principle, and that's to promote our shared expertise and experience through empowerment, education, and community engagement to create inclusive businesses and organization settings. And so through our mission, through our vision, through everything that we kind of observed, we really kind of worked hard to kind of create this specialized approach. We really take time. We take the time to get to know your business, your organization, the members that are working there, the leadership, because we really want to provide that quality assessment, creation of goals and recommendations. But guess what? You're not on your own. We support you through every step of the way. I get daily emails, phone calls, texts. They know that they can come to me with questions, with, hey, what are the next steps? And what I've noticed is we may start with a couple of goals, and because of their comfort level, because they really see the impact that they're making, they'll call me back and say, okay, we want more training, we want more supports, we want to do more. And I think through that partnership, that's what we're starting to see, and we're really excited about that. But not only are we having that specialized approach, we really wanted to make sure that the voices of our autistic self-advocates and families were also being heard. So it's not just our professionals. We are very excited to be working with a group of adults. We are going to highlight Jose Roman, who's our original adult, who's really helped me get this project going. And you'll see some of the work that he's done. But really having our community advisors drive it to help create a supportive and a neurodiverse community. So we've been excited to also highlight them as well. And so kind of how we were talking about this, we really do that individualized approach. So we look at the company and we ask ourselves, okay, are you an organization that's really just needs that sensitivity, customer service, and we'll tailor the programming to that, where you don't maybe give so much direct service, but you are engaging with customers, and we'll tailor those trainings to that. Then we also look at it, is this a program inclusion? Are they providing direct service, whether this could be a camp, a museum, dentist, doctor's offices, where you're having that one-on-one time? And then we make sure that the trainings are tailored so you have the tools and the right strategies to support any customer that comes into your business. And then I always like to add this plus employment. This is my adult manager of adult real kick here, because what we started to see is many of our organizations were saying, I'm not really interested in employment. I'm not sure what to do. But when they started getting the training, when they started to see the supports and what those supports can do for their customers, then they start to say, okay, well, you know what? I think I can do this. And we really try to do is emphasize it's not a requirement of the program, but we do want to show you that we will support you through the employment process so that you can add this into your business support as well. And so this is kind of just showing you that there's a steps. I'm not going to go into step 1, step 2 of how we do it, but I really want you to see that our team has kind of worked together to create that systematic approach where we are contacting you, where we have an action plan. And we do have a manual that hopefully, we'll be able to share with the community of how we actually implement this with our partners. So kind of what we were saying, we do have one certain steps where it's more focused on that customer service sensitivity, more of that, intro to autism, and how to really effectively communicate with your customer base. Again, what's really great about some of the programs is we actually do a walkthrough. We'll go into your business space. Obviously, we've relied heavily on Zoom during this time to kind of maneuver the video through your business, but we will go in there, see the space, and then be able to give you some good feedback and recommendations. Again, some of our community advisors will join us on this. And then we look at our program inclusion. So if you are an organization that does that direct service, we are able to conduct the trainings of inclusion and program supports so that you feel like you have the tools where you can then implement some of those inclusive strategies. Again, we provide some referrals for accommodations, modifications, and then we've got those really great check-ins. So you're able to, coordinate, hey, listen, we're having an issue here, or we need some support there, and we can kind of continue that collaborative partnership to making sure you can implement this effectively. And then we look into our employment steps. So what's another great feature is maybe you start off as just a program inclusion or a support service level, and then you start to tell us, hey, maybe I do want to try this out and employ an adult, and we will conduct that training, especially for the strategies for successful employment, and then coordinate you with the right supports to make this a smooth transition, not only for the business, but for also the adult as well. And so I know that I kind of flew through this because I really wanted to highlight one of our amazing partners, the Broward Center for the Performing Arts. I, of course, asked for like a 3-minute video and they gave me this wonderful production. So I'm really excited to share with you because I know that I can talk about this till I am blue in the face, but I want to make sure that you guys can then see what it actually has done from the partnership through that community impact. So I'm excited to share that with you now. Hopefully you'll hear it now.
Hi, I'm Kelly Shanley. I'm the president and CEO at the Broward Center for the Performing Arts. Most people know the Broward Center is a place where lots of great Broadway shows and concerts and other performing arts happen all the time. And of course, they are correct. But what most people don't know about the Broward Center is that at the core of our mission is a deep desire to find ways to use the arts to serve our community in meaningful ways. We also like to find ways to remove barriers to the arts and offer arts experiences to everyone in our community. So our partnership with CARD really allows us to do all of those things. CARD has helped us find a way to make attending performances possible for people on the autism spectrum. We did that with sensory-friendly performances, and that opened the door to a collaborative partnership that in many ways helps us now continue this work and work with them to find even more ways that they could better serve the neurodiverse community with arts-based programs, and we could reach new audiences that didn't previously feel like an experience in the theater was going to be for them. So it's really a beautiful thing when you can find two organizations with a common interest and an alignment of purpose. Things can really take off, and lots of lives have been positively impacted by the work that we've done together. So at the very beginning, the inception, if you will, of inclusion programs for kids and adults on the autism spectrum or with other developmental disabilities was work that we did with the Exceptional Theater Company, ETC. We partnered with them to offer special stars classes, which allowed teens and adults on the spectrum to actually perform. Then we worked with TDF, the Theater Development Fund in New York, who've been our advisor from the very beginning, and they were able to share lots of knowledge and information about autism-friendly productions on Broadway, how those were done, the training involved, and that eventually resulted in our first sensory-friendly performance of Tarzan. It was a pilot production with Slow Burn Theater Company, and it got such a fantastic reaction from the community. This involved training for all of our staff, all our volunteers, and the actors, which really helped them tune into how to create the right environment for the folks that we were inviting into the theater. It was really enlightening for them, and it was really well received by all of them, especially when they understood that we were going to make theater possible for people who it had not been possible for before. So through other funders, we were introduced to CARD, and they really allowed us to take our work in this space to another level. They really helped us tune into refinements to our program that made it even better for the people who were participating. So our goals right now are to add more programming in South Florida and more opportunities for the neurodiverse community to engage with the arts, both on and off stage, as an observer, as a participant, and as I said before, using the arts as a tool to help CARD and the neurodiverse community here in South Florida achieve new things and have new experiences.
We knew that in order to better serve our neurodiverse community, we needed to find the right people and the right partners who believe in what we believe, and that brought us to UM-NSU CARD. And immediately, we knew that we were meant to build great things together. We announced our Autism Friendly Initiative partnership in front of a full theater with over 500 families in attendance during Sensory Friendly Shrek the Musical. On that day, the Broward Center was recognized with the Autism Friendly Organization Award. Their guidance and support has allowed the Broward Center to build capacity and reach families and individuals that we couldn't reach before. It connected us to our community with a genuine commitment to inclusion. And as a result, our community became more connected to the arts. With their support, we provide an exceptional and unique program for South Florida, unique in the region, which is almost always sold out. Thanks to CARD, staff members have been benefiting from the free trainings on support, strategies, and customer service skills to better serve our neurodiverse community. And with the guidance from the UM-NSU CARD team, we were able to create the first ever Broward Center social story, which narrates the journey that families take when they come to the theater for a sensory film show. It highlights all of our engaging activities and details the many accommodations at our theaters. Some of the engaging activities highlighted in the social story are the Arts and Crafts Station provided by Young at Art Museum, another one of CARD's Autism Friendly partners. It allows our neurodiverse community to complete crafts related to the show, express themselves, and be creative. We provide a touch table with costumes and props from the show that allow our families to get familiar with what they're about to see and understand that the props they'll see on stage are not real. We also invite a princess who loves to welcome families to our theater. Our princess meets everyone, interacts with families, and takes photos with them. And frequently, our guests have the chance to enjoy a meet and greet after the show, meeting the characters and creating lasting memories. We also provide accommodations, such as a quiet room with a therapist on site where families can watch the show with no sound. We also provide fidgets and noise-canceling headphones. Having a partner that can provide their feedback to our programming is important. The UM-NSU CARD team advises us on which shows to bring to make sure we are fulfilling the needs of our community and offer diversity of programming, ranging from Broadway to ballet to Brazilian voices. Our goal is to use the arts to connect to all segments of our population. We also work with Jose Roman, a young adult with autism spectrum disorder who serves as an advisor to the Broward Center and comes to see the shows before the public so that he can provide his feedback in case we need to adjust any scenes to make it more comfortable for our families. He also designs the arts and craft videos that we use for our virtual programs, which we introduced right after the pandemic began. When COVID hit, the Broward Center team and the UM-NSU CARD team created the All Abilities event series that provides free interactive virtual events where we bring engaging art experiences to families to the comfort of their home. Some of these activities include acting, dancing, and singing, featuring guest artists who often bring Broadway theme and music. We also introduced several South Florida local musicians to the series, with programs ranging from flute to jazz to drumming. As guest artists, this opportunity allowed them to be involved with our neurodiverse community and receive training. We often hear from them that working with us on these programs is one of the most uplifting things they do. Being in partnership with CARD also allowed us to form relationships with so many community organizations, such as the Friendship Journey, who we partner with along other groups to create the Wings of Friendship Camp, a free virtual camp whose purpose is to welcome our community of all abilities to share our voices, spend time together, and form relationships and friendships during this time. All of this comes to show that when we come together, there's nothing that we can't achieve.
Many thanks to all the funders who have helped support this kind of programming with us and here in South Florida. And thanks to our friends at CARD, this partnership that we've formed with them will allow us to continue to grow our programming. And when we talk about collaborations, it's relationships like this that are key to the success of using the arts to advance broader community goals. We're so happy to be working with CARD, and we're looking forward to all the possibilities ahead, serving the autism-friendly community and building on all that we've learned and achieved together.
Okay. So, that video, I had to take a moment and thank Gustavo Padrino and the amazing Broward Center for Performing Arts. It still makes me a little choked up. So, I really wanted to just show we cannot do it by ourselves. And I know many of the speakers have kind of highlighted that when we work in our own bubble, we can only do so much. But when we create collaborative partnerships, we build within the community. And looking at CARD's goal is to build capacity, is to build opportunities. And through all of these wonderful partners from Young at Art, Broward Center for Performing Arts, American Pediatric Dental, Miami-Dade County, Jackson, Miami International Airport, the City of Parkland, Code Ninjas, Art Grounds, Adrian Art Center. This is just I hope this is just the beginning, where I just want every family to have every opportunity, no matter where you are, no matter what your abilities are. You are a part of this community, and we are here to help support you to make sure that you can provide quality service, quality care to any person that walks into your door. So I'm very proud of this project. I am proud of the colleagues that I work with on this, and I'm really happy and very honored to share this with you, and hope to continue to expand this program as well. If you want any other additional information, please look at on our website at www.umcard.org. You'll find more information. If you are a business or know of a local business, also feel free to submit an application to kind of be one of our partners as well. So thank you. I appreciate your time. Thank you so much for spending the whole day with us. And I will open it up. Louis, I don't know if there's questions.
Cece, I'm going to take it from here. But yeah, just stop sharing and we will open up the whole. There we go. Hi, everybody. I'm back. I'm not locked out of anywhere right now, which is good news. I am, again, Michael Alessandri, proud Executive Director of CARD. Happy to close out the day with all of you. I'd love to see all our speakers, please. It would be good if everyone could, cameras on, would be great. Thank you. It looks like we have many, but not all, but thank you for being here. I wanted to, there are a couple of questions in the chat and we will certainly pivot to that. I think there's some comments as well, which is wonderful to see. And yes, thank you all for being here and thank you all for your positive feedback. I want to thank the speakers for taking the time out of a Saturday to share with our community. It's such a great gift to do the work that we do, and I think we all realize how blessed we are to be able to kind of pursue our passions and share our the inspiration, which is the individuals with families, individuals with people with autism and their families, share this information with all of them. But the speakers are really, we're very lucky in South Florida, particularly at the University of Miami and Nova, to have some of the shining stars in autism research. Dr. Messinger, Dr. Udine are really leaders in their field, and Dr. Gutierrez, Dr. Parladay, and others are really kind of coming up right behind, doing some extraordinary work in their areas of expertise as well. And I don't see Cecilia here, but I thought Cecilia gave a lovely presentation about the work that she's developing at the University of Miami. So I want to thank all of them. And Cece has really been leading the charge in terms of our Autism Friendly initiative, and hopefully we can get into a little bit more of that in terms of the partners we're working with and the impact we're having. There's been, an enormous amount of interest in the work we've done with Miami International Airport, a lot of interest in the work we've done with Jackson Health Systems in terms of making their urgent care centers autism friendly and making their emergency departments autism friendly. And we also have, an extraordinary opportunity now in Miami-Dade County. Miami-Dade County Board of Commissioners passed a resolution authorizing the CARD Center to work with the county on developing an autism-friendly initiative that's county-wide. So we're working with all law enforcement, police, fire, corrections. We're also working with all of the public libraries. Our team has already trained over 50 public library staff throughout Miami-Dade County. We're also working with Parks and Rec and Transit. So we're looking for that to roll this model out on a bigger scale, away from the individual businesses and more to the larger communities and municipalities. And before we get into any questions in particular, I want to introduce everyone to Jairo Arana. Jairo Arana is one of our constituency board members, and I'd like him to introduce himself. Jairo is here because he's a board member. He's also here because he is a person with autism, or an autistic person in his case. And one of the things we might want to talk about, Jairo, early on is, I did mention early in my talk about some of the challenges with nomenclature. When you have individuals who have more profound autism and higher functioning individuals who are self-advocates, there's a real disconnect in terms of how we're talking to each other and about each other. And we can get to that, but why don't we start with having you introduce yourself, and then we'll let this kind of flow organically.
Oh, thank you. Hi, everyone. Hi, Dr. Alessandri. Thanks for having me here. Oops, I'm a little tongue-tied. Thanks for having me.
You can drop the doctor. We know each other too well for that.
Hi, Michael. Thank you for having me on the panel. I've been watching all morning. I got my ticket on Eventbrite. I sent a message to Luis, and I'm like, oh no, I bought it on I didn't buy it. I registered through Eventbrite. Then I'm like, no, I had to just do it separately through the link that was sent to me. And I'm like, oh no, I wasn't paying attention. Bad Jairo, not listening to instructions. But my name's Jairo Arana. I work at the Mailman Center for Child Development as a clinical program coordinator. And I was diagnosed with autism late in life, like 8 years ago, just when Asperger's was being added into the DMS-5 as autism in general. And that was like, there was a transitioning there, and there was a transitioning in my life where I was like diagnosed with autism. I'm like, why am I being diagnosed now? Why not before? I was living abroad. I was living in Latin America, and I, maybe, I don't know, there wasn't that much awareness about autism, I guess. And even here in the United States, we're learning about autism. And I've been learning about autism by interacting with other adults on the autism spectrum, which is why I make it a point to be like, participating in CARD when we do our adults adults on the autism support group and job club. It's so I can see the perspective of other adults on the spectrum, because my autism is different from another person's autism. And so it's like, and it's one of the things I've learned that also makes it a little challenging. And sometimes for us to even interact with each other, sometimes we kind of like, find it, our social engagement can be a little challenging. But yes, so that's, I don't know if I went over because I was supposed to just introduce myself.
Absolutely great. We're super, Jairo, we're always delighted to have you with us. I mean, you're such an important board member at CARD. I think you know that. I think we rely on you for, your insights, your personal thoughts about not just what's happening in the world of autism, but really what we're doing at CARD, just to make sure that we're staying on point, that we're really making sure that we're reflecting all the voices of the community. I think one of the challenges is, even in the research realm, right, having autistic voices inform the research agenda, I think is so important. And I think let's maybe start with that initial point that I was making about nomenclature. There is this debate that seems to be raging at the moment between, parents of kids who are more severely affected and then the self-advocacy community. And I think, I happen to agree with Kathy Lord and others that we need to figure out a way to have separate nomenclature, that we're talking about, it's not helpful to us to be lumping, even though I think it's better than where we were, I don't think it's as good as where we can go in terms of how we can classify the different kinds of presentations of autism. So I just wonder if you, as an autistic person who's now not only immersed in the world of autism, but personally, but also professionally, I wonder if you have thoughts about that.
Well, thank you. Thank you, Michael. This is something that I talk about with our LEN trainees, our leadership education in neurodevelopmental disabilities, with my colleague and mentor, Shelly Bear. Shout out to Shelly. Hey, Shelly. We do our talk about disability. And one of the, I'm the one with the invisible disability, which is autism. And I share my story about the late diagnosis and everything. And I remember that there's a parent who would do these talks, has a child on the autism spectrum. And it's called the spectrum. It's like, it's very linear, and you see the colors of the rainbow. It's like, the spectrum, the color spectrum. And I remember her saying, that's not, what if this autism spectrum was really like a circle? It's round. And I'm like, I'll look at that, and that gave me an idea. I'm like, oh my gosh, yeah, that is so true. But wait a minute, that's flat. That's two-dimensional. And that's when I came up with this. And this, to me, is what autism is. And also, it's also about neurodiversity and neuroplasticity, because the more you learn, the more you're exposed to the world, the more you broaden. I've learned, my autism was I was so deeply autistic or deep in the spectrum that sometimes my social faux pas and not get, it would manifest itself by socializing, interacting with others, getting a job, and being given that chance, that opportunity. I learned that's what I love about the brain. It's like it's almost like a muscle, where the more you use it, the more connections, the more you connect your neurons, the more you start learning skills. So I do believe in neuroplasticity. I'm not a scientist. I do love science though, but this to me is what it's like. I'm in the spectrum. I feel like I'm somewhere here. So this thing where it's like this, you're either, high functioning or low functioning, that's like placing, it's like we're people, not machines. Where can you function? Or it's like, no, my job is not to function. I just exist. I'm here. I want to be valued for who I am, not, can I function? It's almost like, giving a value, a very utilitarian value. It's like, we're people. It's not about high functioning. And if I'm high functioning, which, okay, great, good for me. But, so that means someone is low functioning? That's not right. I don't like it.
Well, it's also not fully appreciative of the challenges you have, right? There are times when you probably feel very high. I mean, we all do. I felt very low functioning this morning when I got locked out of my office. My point is, I mean, there are moments, I think, there are activities, there are aspects of life, there are moments where you feel competent and you feel capable. And then there are other situations where people assume you should be competent and capable, but yet you feel like you don't necessarily have the skills to bring to bear to those situations. So I love that visual that you just showed us. It's also a pretty good toy to have in your office.
I love it. It also relaxes me. I do.
It's very relaxing. But I wonder, maybe we'll shift to Daniel and Lucina now, because I do think, one of the things that I mean, first of all, I think we've really assembled a great team at the university and I think the portfolio of research that we're doing now is higher than we've ever done before in terms of the autism world. We've always been really strong on the clinical and service side of things. And I think having you and Daniel and Lucina there and others now doing independent research as well, not just CARD staff participating as part of, I think we've really grown the portfolio and I'm really pleased. And I think the future is really bright. But I wonder, I think a lot of the times I just simply think about, what does it all really mean, right? Like we all do what we do and we hope that it contributes. But I wonder from your perspectives, particularly Daniel and Lucina, who really are kind of if you excuse the term, the more hardcore researchers of the group today, the scientists, if you will. I mean, I wonder if you think we are in fact making progress. I wonder if you think we will have a moment in time where all of this independent research we're all doing really integrates in a meaningful way in terms of some of the discussions we were having earlier. I think, Lucina, you were talking about, new ways of conceptualizing these diagnostic categories and these disorders. And Dan, I think with some of the technologies that you're using and bringing to bear, I just wonder where and how it all kind of meets and what the impact is at that moment. Or if there is even the possibility of such a moment, or do we just continue to plug away at answering questions that hopefully will lead us to a bigger solution, if you will? And not that there's really anything to solve, but we do want to understand autism better, and we do want to create those pathways where we're reducing suffering for people who are in fact struggling with autism. Not necessarily, I don't think anyone on this group is of the mindset that we need to eradicate it. I think that's some of the criticism many researchers get, but we do want to make those difficult moments less difficult for the people. So I wonder what your thoughts are just generally, and there's not really a specific question there, just more of a kind of conceptual thought about where we are and where we're going, and will we get anywhere meaningful?
I love this topic, if you don't mind me jumping in first.
Yeah, go for it.
The reason I think it's really important, especially now, is because you hear people say things like, how did we develop a vaccine so fast? I don't trust something that came together in 1 year. Well, guess what? This has been going on for 50 years. That's what basic science is, understanding how these molecules fit together and how our immune system works and how we can boost it in certain ways. That didn't happen in a year. That has been going on, and we've known a lot about viruses and about immune systems. And that's why when it comes to putting together a vaccine in 1 year, it seems like it's happening quickly. So the basic science that happens behind the scenes is often not very flashy or exciting or newsworthy. You don't, hear about people sitting at the bench with pipettes. It's just, or the mice that go into these trials. It's just not that, flashy. But as soon as, we have a public health crisis, the question is, where are the scientists? And that's what they've been doing all along. And I think it's similar, it's analogous to autism. I'm studying the brain of individuals who are diagnosed with autism. Will it eventually lead to some change in the way we treat or diagnose the condition? Hopefully. I'm not sure right now because we're so early in the process. We've only started this work as a field, let's say about 30 years ago, if that. The techniques are evolving, our understanding of the brain and how it develops are evolving, and we're learning more every day, literally every day. I can't predict if the work that I showed you today is going to lead to something downstream, like a revolution in the way we we diagnose autism. It very well could, or it could lead to something else altogether. But because we've spent so much time figuring out the basics, we're in a better position to, to do the translational part. So I think Dr. Fauci gave a good response when people asked this, which is we didn't do it in a year. We've been doing it. We're still doing it.
I think that's great. And I think it's important that you clarified that and said that, because we do hear from parents who've been around for a while now in our autism community who have participated in this study or participated in that study. And really, I think they question whether that involvement has been meaningful or substantive, because it hasn't necessarily led to a change for their particular family or child. And I think it's important for anyone who wants to participate in science to understand that the contribution is bigger than your individual contribution. Like, you're just contributing another layer of information to this ever evolving kind of fabric that we're trying to sew. So I appreciate Dr. Fauci and also your comments there. I wonder if Dan, if you want to weigh in on that.
I think that's true. I think that families contribute and families' contribution is invaluable. Sometimes we feel like that as researchers, like we put a study out there, somebody else picks it up, they don't pick it up. We're helping to build a fabric, we're helping to sew a fabric, but we don't know where each study will lead. Mm-hmm. I do think that you were asking, like, when's the moment when it all comes together? I think that the tapestry folds in on itself, if you will, at various times. And I think right now, together, this panel is one such moment. So I think change is coming. Let me sketch out a couple of them. I mean, I don't think there's any doubt that computer vision, some of the stuff that Annabelle was talking about, Dr. Gutierrez, will be a part of autism screening, let's say in the next 10 years. I mean, the apps are already there. We know some of that stuff is on your iPhone or Android, and more will be coming. But it really strikes me in terms of coming together that it's important that researchers like me who are doing a little bit of that work, and Jairo and Sylvia, that we're kind of in touch and have opportunities to talk to one another. Because, it's not all good just if I have an app diagnosing my child. I mean, for God's sakes, we want some human touch and human wisdom in there. And I think that as, we learned something, Michael, on that committee yesterday, that high-pitched vocalizations, wow, that's really a signal. So can we turn that around and then go to the clinician and say, I mean, wherever you are with things, but we did pick this up, that might be something to notice. And we don't know what the clinician will say. The clinician will probably say, yeah. I mean, obviously we knew that. I knew that from the second the kid walked in the door. But maybe sometimes it's value added, like stuff in the schools. Yeah,
I love what you're doing in the schools, and I think it's super exciting. I want to introduce Dr. Parladay again. One piece of history or part of her biography that people don't know is that she started as an undergraduate working with Dr. Messinger. So she's now come full circle. She's back at the U as a staff psychologist, hopefully becoming a professor sometime this year. But Meg, kind of adding to what we were just talking about in terms of those signals, in terms of those cues, and
Michael, I think you're frozen.
Oh. From your vantage point as someone who is in the trenches on a regular basis, like what are you seeing in terms of the benefits of some of these technologies that are being deployed now in terms of diagnosing kids? What would the utility be of an online screening tool or objective measurements, or even some of the stuff that I think we all know Jerry Dawson is developing in terms of an app for early screening identification? How useful is that to a clinician, in the trenches doing diagnostic assessments? And could it have been helpful in the context of COVID, which we understand, your team really struggled with figuring out a legitimate way to do, diagnostic evaluations and identify the kids. And then of course the delay in finding intervention during COVID is a whole other issue. And whether or not intervention presented virtually even works is still an open question. But I wonder if you can take that and then maybe we can circle back to treatment and PCIT.
Yeah, I think that's a wonderful question. I think that it would absolutely and will continue to be very valuable. For us as clinicians, we don't rely on any one source of information when diagnosing a child or when considering that as a diagnosis. We try to collect information from multiple sources, the family being the biggest source. So having, these additional pieces of information that might give you a viewpoint or information that you couldn't otherwise get in the clinic is extremely valuable. And I would say, yeah, in particular during, health crises like the pandemic that we've all been going through, where we were limited in that we could not bring families into the clinic. So we had to rely more heavily on these additional sources of information. I've had parents send us home videos, just video clips that they've taken of their child to be able to give us a glimpse as to what they've seen and what they experience on a day-to-day basis. So I think that the apps and the technology that and the research that's going into those programs right now is really, really exciting as a clinician. I'm not concerned it's going to put me out of a job, as some people might be, because as Dr. Messenger said, like we really do need all of these pieces. We need that human interaction. We need that person on the other side of the app to hear, the parents' concerns and to be able to be that empathic kind of ear and guiding force and getting them connected with the other services that can be helpful for that child.
And we also know from the work we're doing on our ACE study that, even when you do have a positive screen or a positive diagnosis, I mean, you really need, those kinds of gentle handoffs to, and sometimes not so gentle, to services. And, we're using motivational interviewing in the context of that study to really mobilize pediatricians and mobilize families to action. And even that's still challenging. There's still some of these, so I think just having the technology available for screening is simply not going to be, enough. I think it's helpful to alert parents of concerns earlier and validate their concerns if they do in fact have them, but it doesn't necessarily, translate to action, right? So there still have to be, people like us involved in the care and the coordination of care for people with who are at risk for autism. I'm going to circle back to Lucina and ask, do you envision this is a setup question, sorry. Do you envision any opportunity to scan younger than 7-year-old kids? And because I do think if we think about what Meg talked about in terms of PCIT and Cecilia talked about in terms of some of the social communication training that she's doing with parent coaches and parent mediated instructional practices, tracking brain change, I guess, secondary to treatment seems really exciting to me. So is it feasible? And if so, how would we do that?
Yeah, this is a great question. Just because our lab isn't doing it doesn't mean it can't be done. So there are many groups across the world and the country really who are scanning sleeping individuals, sleeping infants, sleeping toddlers, sleeping 4-year-olds. So it's a little bit harder because obviously you have to wait for the child to fall asleep before you can, collect the data. But it can be done, and it's done at many of the research centers. And so it's something that our lab has not specialized in, but we're collaborating with a group in San Diego that has collected data from 1- and 2-year-olds. This is before diagnosis. So these are the kinds of studies where you can try to use brain imaging metrics to predict future diagnosis. You can really do prospective studies. And that's one of the most exciting things on the horizon now is using, brain imaging based potentially biomarkers to help aid in diagnosis, as we were just talking about. So I think that's definitely something that's coming up. What our group specializes in is using these resting state MRI scans. And as you can imagine, when you're sleeping, the subject doesn't have to do anything. They're in a resting state. And what's great is that we've moved so forward with the methods in terms of using them as fingerprints to relate to different behaviors. And the field of resting state fMRI, we call it connectomics, has just exploded. It's the kind of thing where we're just learning so much from these brain scans of people doing nothing that we can take the sleeping data and just learn so much about what behaviors we think might emerge a few years later. So I think this is really exciting. I think what our lab is going to be doing is really continuing to collaborate with those groups who have a lot of expertise in obtaining the sleeping infant data, because we're not equipped to do that ourselves. But as I was mentioning during my talk, there's a lot of data sharing going on now. That's a big push because we realize we can't do it all alone. We might have the technical expertise, but we don't have the ability to, scan kids at night. So we team up with people who do. So I think this is a really exciting future direction.
And is there a feasible way of integrating some of the genomic data we're collecting, like via Spark, and what value does that add to what you're doing, and even to what Dr. Messinger's doing in terms of the objective measurements? I just wonder if you have thoughts about that.
Yeah, another thing where we don't have the expertise in-house, but what the genomics data can do is help us with the heterogeneity problem. So are there specific, patterns that associate with specific brain connectivity patterns that associate with specific behaviors? I think that is the key to, what everyone has been discussing all day, understanding why individuals can be so different from each other, even though they all fall under the diagnosis of autism. So the genomics part is critical for that. But of course, as you're doing with Spark and other studies, you have thousands of subjects there. And we only have the money and the resources to scan a few, maybe 100 at best. So there's a mismatch there between what, the data that needs to be collected and the resources that are available to collect it with. But I'm still hopeful that there will be more funding coming for this kind of integration.
Cool, great, thank you. So Cece, there was a question in the Q&A about how people can help us with the Autism Friendly initiative. And I think it would be great to talk about, I want everyone to know that this is happening really on a statewide basis. All of the CARD centers have launched Autism Friendly initiatives within their communities, starting with the University of South Florida, which has a very well-known project with the city of Tampa, and then others now are also rolling out their initiatives. And we've come on pretty strong in the last year, thanks to your leadership, and I think have had some real impact on some of these businesses and municipalities and counties. So what role could a clinician play, or a family member play, or anyone listening today in facilitating kind of an expansion of that project?
Yeah, that's a great question. I think there's different roles. So as a parent, I think you can kind of take the approach. We've all been in that situation where maybe our child isn't fully included within a business and organization. I think the first step is always about the education and awareness. So as a parent, maybe not in that moment, but when you have a moment, kind of going back and saying, have you heard of CARD? Have you seen some of the work that they do, the collaborative partnership? Here's their information, here's their website, and just give them a heads up that we're there. Because this is, and what's great, and I want to stress, it's a free service. Just like it's free for our families, this is also a free service for other businesses and organizations. So you can always just let them know that we're here, what we do. I think parents are very powerful in terms of sharing that information. And then I think as clinicians, Michael did mention, we are not the only ones doing this. I think what's great is I learned some of the stuff that USF is doing. We all kind of collaborate within each other. And I think by creating this manualized program, we're able to kind of continue to replicate and provide this support within the community.
Thank you very much. Meg, there was a question earlier, and I think you addressed it, but I think it's an important enough question to kind of put out to the whole group. And it was the question essentially of PCIT, versus quote unquote ABA or some other approaches. And I wonder, you just stick with the ABA comparison. I wonder if you can address that, because I do think there's often a misunderstanding of PCIT. I don't think it's a counterpoint to ABA. I mean, it uses obviously behavior analytic principles. So will you speak to that, briefly, and see if we can get some more clarity about how those two things kind of can go together? One of the things that I've always pushed parents to think about is to not think about the either or, but to think about ways to integrate practices. Back in my old days, we talked a lot about, and I mentioned this in my talk, I used to sit in the audience when Eva Arlovas and Stanley Greenspan were debating interventions, ABA versus floor time. And I always felt like that was, or teach versus ABA, I had that debate as well. And I always saw a really clear path for integration of those different approaches, because I thought they targeted different layers of functioning. And I just think, it's whenever we develop
Michael, you froze.
Did you hear that? Did you lose me?
You froze for a moment. Yeah, you froze.
Oh no, sorry. Did you hear any of me?
Yes,
Okay.
I think I can start answering the question. I just didn't hear probably your last statement.
Oh, sorry. I think it's my internet. My bad.
Okay. Yeah, the either or. Yeah, I don't think it's an either or question either. And that was my response. It's a what, what can you get from this therapy? What can you get from that therapy? What does your child need, first of all? What do you feel like you're missing? And let's tailor the interventions to those needs, right? And so it really isn't always a one size fits all. And that speaks to the heterogeneity of autism again. But, I think that for Pcit, it's the way I look at it is really about supporting the parents and the family and the family unit as a whole. So if you feel well supported in ABA and you do have that parent coaching, that parent training, you know what to do when the therapist leaves, then you may not need additional services. We don't want to duplicate services. We want to support and supplement. And so the Pcit offers slightly different things, even though, as you said, the underpinnings and the principles that we use to teach the skills and, get the outcomes are very similar. So yeah, and I work with kids that are receiving many different types of therapies, ABA, being one of them, and possibly speech and OT. And when that's happening too, you also want to make sure that there's that coordination, right? Like, so that all of the different providers are communicating to one another. And that's usually my first question when parents tell me they are working with these other therapists is, can I have your permission to speak with them? Tell them about what we're doing so that we're all on the same page. So I think that's an important piece too.
Yeah, I just want to add to that. I think, one of the reasons the CARD centers were created in 1993 was essentially to be an objective voice in helping parents determine the best way forward. And part of that is figuring out which combination of treatments makes the most sense, where the evidence lies, and what seems most relevant in terms of the evidence base to the particular presentation the client is coming in with. So I would say to people who are watching from Florida to, rely on the experts that are within the CARD centers to get those recommendations, case management. I mean, the reason CARD is free is so that you can come to us and actually get objective opinions about what we think is the best path forward for your child or family member. So keep that in mind. Like, take advantage of the objectivity of the freeness too is pretty good, but the free services are in order to allow us to be completely objective. We're not sending you to a clinic that we necessarily benefit from, right? So I think that's a really important, or a therapy that we will benefit from in some way. Jairo, I wonder, circling back to something that we were talking about earlier, I wonder what your thoughts are about, in the context of research, how do you feel about, as an autistic person, about genetics research? Is that something that has concerned you? I think there's been a lot of concern in the self-advocacy community about what the downstream effects might be for discovering autism risk genes for the autistic population. Obviously, we've now discovered there are 153 plus risk genes, so I think it diminishes the risk to some extent. But we always try to be very thoughtful and sensitive with our autistic, clients about even the research paths that we're on. But I really find tremendous benefit, and maybe I have a particular interest in genetics, which I talked about earlier today. But I wonder how you feel about that kind of line of work.
Thank you, Michael, for the question. It's a very good question. It's very important because one of the things that many of us on the spectrum, many of us autistics or people on the spectrum are concerned with when it comes to genetics is there has been a history in the past where it's like, it's good to understand autism. And the way I see it, we want to understand and we want to be accepted. And I am who I am, and I'm glad I like who I am. I have to learn, and all these things, and I may have my challenges, but, to see autism as something to be cured, or that's something that makes us very nervous, because I wouldn't be who I am without my autism. I mean, my autism doesn't define me. It's just a part of who I am. It's one of the many things. I learned this from my mentor, who's a social worker, a licensed social worker. They do the identity maps where it's like, okay, this is part of my identity. I'm a man. This is my race, my ethnicity. And my autism is part of my identity. It's one of the things about me that, it does have its challenges. I've had my meltdowns, and I hate it when I have my meltdowns, but it's part of who I am. Mm-hmm. And I work on it, but I
Yeah.
don't think it's good to, my concern, I support Spark because, okay, let's understand autism, but let's, be very clear that many of us autistics or people on this autism spectrum don't like the idea of autism to be eradicated. That's something that really worries us. We don't want that.
What I've always appreciated about you, Jairo, to be very frank and clear, I think is, you've always been very mindful of the fact that your presentation is your presentation, and you understand that there are other people on the spectrum who really do struggle to get through daily life, and their families struggle as well. And I just want to say publicly that I very much respect and appreciate your openness to understanding that your sole singular experience is not necessarily reflective of the rest of the spectrum. And I think that's really important in this conversation, that we at least try to have that ability to understand the perspective of the parent whose kid is really severely aggressive or severely intellectually disabled and really compromised in their ability to function on a daily basis. And I think sometimes, and CARD has been guilty of this too, sometimes we sometimes put forth these stories of great success as the example to set out there for the community. And I think we have to tell a more complete picture. And I think some of the research we do, which is focused on early identification, early treatment, even our adult services work, I think tells a bigger story, if you will. But I think we as a community have to tell all the stories, not just the ones that the media likes best, right?
That's yes, Michael. Thank you for saying that, because just yesterday I was having some emails exchanges with members of your team at CARD, where I was like, listen, it's nice if I tell my story, but I think we should hear all our stories, because again, my autism is my autism. I'm doing fine, but what about the person who's struggling, who's unemployed, underemployed, and they just want to be out there. They just want to be accepted. They want to participate. They want to be social, and they're isolated, and that's not right. So that's one of the things that I like to mention. So I wanted to make sure I wasn't the only person on the panel with autism, but things happen where but to tell all of our stories. And one of the things that is very important that it could be mutually beneficial to all of us is that many of us on the autism spectrum, I studied film. Many of us want to be filmmakers or video game designers. We're all very visual. And if we can somehow be able to tell our stories visually, and I know many adults on the spectrum who love, video, film, and to tell our stories, and this is what it's like, then that would be helpful. Mm-hmm. And really quick, I also reached out to Dr. Gutierrez because I was blown away by his presentation. I'm like, oh my gosh, this is amazing. I know so many adults on the spectrum who would love to make those videos. Not to do the videos to train, to learn, but to actually make those videos.
Right. Create those hamburgers visually.
Yes.
Yeah. I think that's great. Yeah. And we know, from our work with many of our adults, what the level of talent is really extraordinary. And many of those talents are being underutilized, unfortunately. With that comment, and I think I'll shift to Cece, and then I'm going to ask Carol and Lewis to chime in and wrap up. We're going to end on time, even though we started a little bit late. Cece, there have been some questions about CARD's adult services. Can you just summarize kind of the range of things we are now doing in terms of adult services? And Jairo's already referenced some of the things that he participates in, but maybe you can kind of wrap it up in a bow for us as we have just spoken to Jairo and talked a little bit about some of our other adult clients. I think it would be helpful for the folks out there who maybe came to CARD many years ago when their kids were young and then for whatever reason disappeared for a number of years and don't realize what we have to offer for the adult in their family.
Yeah, thank you for really stressing that, because I feel a lot of our clients will come back and say, I registered with you guys years ago, but I didn't think CARD was an adult thing, or I didn't know that you guys supported adults. And what I really want to highlight my teammates, Natalie, Dr. Adrian and Jennifer Feinstein, because we really tried to make sure that even in this pandemic that we were able to support adults for whatever success that they felt they needed. So I'm actually going to share with you our team page to share all the wonderful programming that we do. We kind of consolidated everything in a very easy to follow guide. And we love to always see Jairo in some of our programs. We do have some employment focused programs, whether that is job seekers that we will be running in July. And you'll see the information and flyer there. Social gains, some social opportunities, job club, support groups. We've been doing a social skills training series. So really not only just the training, but making sure that our groups can appeal to all types of adults, are all abilities that you were able to see highlighted. That is also part of our adult programming. So there's lots there. I'm going to get the link, so please feel free to open it up. If you have any adults that maybe are not even registered with us, please send them our way. There's lots of great programming for them to join and appreciate in our case management that really focuses on those adult services.
Thank you, Cece. Carol, Lewis, one of you want to have the last word and last directions to the audience? I know there's a link for an evaluation form, so perhaps you can just unmute and close us out.
Okay.
Thank you, everyone, by the way. Thank you, team. Thank you, colleagues. Thank you, audience.
To all the participants, thank you for attending. I did post the link to the evaluations, so if you could fill those out after the conference is over, that's great. The link is also in your handouts as well. And again, obviously for our SLPs, they're looking for credits. Make sure that you fill out your bubble form and fill out the other online form and submit those, and you should be getting your certificates by April 15th. I think that's it. I don't know if Carol has any other comments, but I appreciate everybody attending. I appreciate all our speakers for taking the time on Saturday to be a part of this conference. I think we've touched so many different bases with what we're doing at CARD and what we're doing at the University of Miami, from research to classroom intervention to intervention at home, and so many other different things that we've kind of touched on today. So with that, I'll give it to Carol, see if she has any other further comments. Carol?
I'd just like to end with a huge thank you to everyone involved in putting this together, from the technical aspect to the programming aspect, and especially to Dr. Alessandri and all of our wonderful speakers, to Luis Grana, and to Tony as well for the technical aspect. So thank you so much for joining us for another wonderful Issues in Autism conference. We all learned a lot, and watch for all the other CARD events that we have coming up this spring. So thank you again, everybody, and enjoy the rest of your weekend.
Bye, everyone.
Thank you. Bye, everyone. Thank you so much.
Bye.
Bye, Dan. Bye, Jairo. Bye, Meg.